Welcome to this GACD workshop. I'm Morven Roberts, the Chief Executive of GACD, for those who may not already know me. I'm going to start this session with giving a very short introduction to GACD itself. I'm going to ask Cherie to put up the first slide. And this is really to set the scene for who is GACD. So the next slide, please. And then I think it's the next one after that. So we've said hello. And here we are. So GACD was established in 2009. It's the first and it remains the only collaboration of international research funding agencies who have come together to tackle chronic non-communicable diseases. Together, the Alliance members represent about 80% of global public funding for health research. And the flags depict the countries in which those agencies are based. But of course, we also have the European Commission, which covers a multiple of countries. And we have FAPESP, which is actually particular to the Sao Paulo state in Brazil. Next slide, please. The 12 members that we have at present, we continually sort of hope to grow, but the 12 members focus on a mission that is particularly to support the provision of evidence to inform policymaking, to help prevent or control chronic non-communicable disease, and to reduce inequities in health, particularly in resource-constrained countries or amongst marginalized populations. And we do so by taking three key approaches. We do it by investing in impactful implementation research, and those of you who are on projects supported by GACD should know this very well. We also do it by strengthening implementation science capacity in relation to non-communicable diseases, and we particularly want to do so in those countries in which we are hoping to improve the benefit and control non-communicable diseases, or control or prevent. And we also do it by facilitating collaborations and partnerships. And part of that is in the sharing of knowledge so that together we can support and sustain GACD impact. And next slide, please. And today's workshop has a bit of a theme. We've got the context theme. And what I wanted to say is that when it comes to chronic diseases, we do actually already know that there are a number of interventions or innovations that can work. For example, lowering salt intake, reducing tobacco or alcohol intake are examples of interventions that can work. And these fall within the WHO best buys. But most of these interventions and strategies are built on evidence from high-income countries, where the situation may be quite different to that in many low and middle-income countries and resource-constrained environments. And for that reason, nations very often need context-specific global research to inform their own policies and practices. So today's workshop is aiming to take a little time to explore the context situation. So how do we assess context in implementation research and non-communicable diseases? And we will hear some examples of that context assessment and the importance of context. It also hopes to give you an opportunity to consider context assessment from a regional perspective. And we hope that through this you may meet others who may be grappling within the same context to understand it, or for that matter that you might learn from others who are in very different contexts, and provide you with an opportunity to exchange ideas. I am delighted to welcome Pilvikki Abst, who is the Professor of Public Health at Tampere University, Finland. Pilvikki is a leading expert in the implementation of chronic disease prevention and management in different real-world settings, both in Finland and internationally. And Pilvikki is very well known to us within the GACD, as she also very generously contributes a lot of her time to our implementation science schools that we run each year, where she acts as an expert faculty member. But she's here today to give us a little foundation to set the scene for the discussions that we will all indulge in about 20 minutes. So Pilvikki, welcome. I think you are going to share your own slides again this time as well. Excellent. And just please go ahead when you're ready.
Thank you, Morvin, for the kind introduction. And I'm really happy to be here today, the second time today, as working with the GACD has been one of the really most wonderful parts of my work as a researcher in implementation research. And today my topic is in the context of what, and I'm not talking from an expert position on context, but more like having started to think about context in a more profound way, and trying to find my way on a path that I feel that it will be a long one, and with confusion, but also hopefully rewarding in some sense. And my aim is to prompt you to think about things and not to give you definitive answers. So why is context important in implementation research? Morvin already mentioned that there are evidence-based interventions, and their implementation in different contexts and different cultures, different continents requires more thorough thinking about context. So how can it be explored, and to what extent can findings from context assessments be generalized beyond this the setting? I'm not sure how much I will touch upon that today, but I went to look at some of the literature, and Per Nielsen from Sweden is very well known in implementation science, and he had published a couple of years ago a scoping review on context titled "Context Matters in Implementation Science," and the review included 17 implementation science frameworks, and identified context dimensions on micro, meso, and macro levels. And Nielsen very much comes from the healthcare setting, and that's also one key things in quite a bit of like implementation science comes from the tradition of medical sciences putting evidence-based medicine, putting evidence-based interventions into practice in clinical settings. So that's something that has influenced the thinking. But anyways, the review then or the frameworks in the review are familiar to all of us, I believe, and outline different contextual components for example, the consolidated framework for implementation research talks about the outer setting and the inner setting, and the boundaries a bit fuzzy, and also the process can be thought of as a contextual kind of component there. Another model in the review is the PRISM model that has been built on the re-aim, putting contextual elements onto the re-aim model that outlined implementation outcomes. So there also some of the linkages and feedback loops between contextual components and the outcomes. Also the nature, the multi-layered nature of the context in this model. So the models and the components of context in the models can help you to identify some of the key elements of context. As I said, Nielsen comes from healthcare, implementation science in healthcare settings, and so he kind of separated or looked from the healthcare perspective on these frameworks. And you can see that there is quite a bit of overlap between the different models. So all 17 shared an organizational support component, and then the financial resources, social relations and support were also quite common. But how they looked at context was really as barriers and facilitators of implementation. And the kind of take-home message from the review was that most of the frameworks acknowledge that context is not merely a passive backdrop to implementation, that it is intangible and active, complex and multidimensional. But how this complexity and actually operates is not very well defined. There is an underlying assumption that the context can be broken down to parts, and the parts can be influenced to have an impact on implementation outcomes. Okay, so that review kind of described what the current situation in terms of the frameworks and the different components of context in implementation science are, especially in healthcare setting, but of course the components also very much apply to other settings. So then how has the information on context been used? I was also involved in a review on how context is used in GACD projects. And this work was led by Minna Daivedanam, a colleague based in Sweden now. And the aim of that that review was to answer the how-to dilemma. And their context was seen as multi-level with these levels, also the transnational level there, and the ways of looking at context were these three shown, or themes shown in this figure. So first of all, assessment of context during formative or planning phase of the projects, with different types of methodologies. And then the context relevant information was used in the development of the intervention, informing on ways to adapt the content of the intervention, improve the intervention participation, improve communication with participants and stakeholders. And then during the implementation process, the contextual lessons were helping in the provision of services, in the engagement with the stakeholders, with feedback for personnel to address gaps and training, and then promoting institutionalization. So different ways of using that. But I was wondering that how well do we actually understand context? So we talk about context being multifaceted, and the frameworks help in our understanding what those might be. Also that it's multi-layered. There are environments that are physical and social. There is the hardware, the software, then that it is dynamic and complex and sort of ubiquitous everywhere. But how does it actually then, what do these complexities and dynamics actually mean? And what I find really intriguing is the discussion about the need for a paradigm shift from positivism to complexity. And these researchers, Fadenhauer and Moore and colleagues, claim that implementation of science comes with or from a positivist paradigm. So there the intervention, implementation, context and outcomes are seen as distinct components of a system. And then assessing these components leads to understanding the system as a whole. And interventions are defined purely as a new set of components. And as in the review by Nielsen and colleagues, contextual factors are seen as facilitators and barriers that act as confounders and moderators. And if I think critically, this is how I've also probably thought about these matters, which I find quite understandable coming from the I'm a behavioral scientist by background, but working in very kind of medical field, and from that perspective, and as I said, implementation science comes really from clinical intervention work, but then policy implementation research is probably more familiar with the complexity approach, and I think it's useful to go into that direction a little bit more when we talk about NCD prevention and management of NCDs and how to promote those in communities also often outside the clinic. And the complexity approach really sees context as a core aspect, not as one of many components, and the intervention as a process of disrupting system functioning and then resulting in a reconfiguration of the context. And the way complexity is defined, for example, this is from Pawson, The Science of Evaluation, a realist manifesto from the realist approach, is to see, first of all, the targets, whether the implementers or the end users or beneficiaries, they are active agents, not passive recipients, and their reasoning, interpretation and volition causes the behavioral change, not the policies themselves. So that's something that needs to be understood. Also, that implementation chains are really long, and there are different actors and their interconnections, and that means that implementation is prone to inconsistencies and delays and unintended consequences, and therefore it is never linear. And then, as I said, contexts are an integral part of a policies or programs implementation and the effects. And they are complex, multi-layered, intertwined, and constantly evolving. So even if we say that there are these different contexts in different countries, for example, or different healthcare systems, but they also are constantly evolving, and thus the policies are never implemented in similar circumstances. History and timing of the policy will affect the implementation outcomes. There are always differences, for example, in the readiness to change. And if you think of, well, for example, tobacco policies, then the way people perceive smoking, the prevalence of smoking in the population, all of those things may influence the implementation. Then in terms of outcomes, yes, there may be intended consequences, but also often no consequences or unintended positive or negative consequences that need to be taken in account. Furthermore, we are in a policy-saturated world, and their policies are intertwined, so the impact of a single policy is difficult to assess. And furthermore, the components in a system combine and produce new components, and the system is continually changing, and change is never totally controllable or predictable. So these are some of the key characteristics of complexity, according to Paulson. And similarly, Moore and others, and this is a really recommendable article, talk about complex social systems, and here again, like the emphasis is on the social and how interaction among diverse and ever-changing agents impact how things evolve. And there are different subsystems and larger suprasystems. And the boundaries between these systems are permeable, and there are interactions within the systems and between the systems. And the systems need to adapt ceaselessly. So they respond to changes in internal structures, but also in surrounding system structures, and have a combination of formal rules and more informal ethos. And there are all these feedback loops. Also, there is a propensity towards self-organization. So order emerges through spontaneous interactions of agents rather than central planning. And there are system histories and starting points. So these tap on the same characteristics of complexity as Paulson explained in his model. Moore and colleagues also looked at the complex social systems approach with the MRC complex intervention framework, and the stages in the MRC framework, from intervention development to feasibility and pilot testing, evaluation and implementation, and gave some considerations from this complex systems perspective on what needs to be taken into account. So I'll, for the sake of time, I'm not going to go into that, but really think that we need to acknowledge complexity, the ever-changing nature of context and all the interactions there, although it will change the way that we think about implementation research. And I'm not personally sure what will be the best methodologies, but I really think that we need to team up with people who understand the complexity approach better. Yeah, just to finish with this slide that I've shown also earlier.
Great, thanks so much, Pilviki, for giving us that quite complex overview or comprehensive overview of context. Actually, it would seem to me that when we are undertaking implementation research, context is everywhere. It's complex, it's dynamic, it's shifting, and it's quite tricky to ensure that we are tackling it appropriately. But I hope that some of the discussions this afternoon will help us work our way through some of the challenges that there are.
Have a number of components or a range of characteristics that are involved with these components by the individuals who are delivering or receiving the interventions, or the levels of system that are targeted by the intervention. And what's interesting is that these components and all these factors around it might interact. That makes it more complex. So this is where the context comes in, and it's really, really important. So I want to start with this trial that we did in 2010 to 2012. And Professor Kamran Siddiqui, which some of you might know, was the PI. And I was a trial coordinator on this at that time. It was a pragmatic cluster randomized controlled trial that we did in TB clinics in Pakistan. And we enrolled around 2,000 TB patients and delivered intense behavioral support for smoking cessation. We found that 41% of those who were treated quit smoking, compared to 8% in the control group, which is, a remarkable achievement given a very low resource intervention. However, we couldn't help but notice that the quit rates ranged from 7 to 70% in the 22 intervention sites. So it was hard to grapple with what was happening, because it was the same intervention, it was delivered the same way, everyone was trained the same way. Then why such a wide range of quit rates between the clusters? And this diagram on the right side shows just the quit rates for different clinics. And the bars with the squares and triangles are for the intervention group. So you can see how different that is. So then at that point, we looked at the consolidated framework for implementation research that Pilviki was also talking about. And we wanted to look at the different dimensions of implementation to understand what was going on. So within these different dimensions, we found that the main barriers reported by the health workers who were delivering the intervention largely related to the complexity of the intervention itself. For example, the duration and number of sessions, and the number of behavior change elements that they were supposed to deliver. But what was also really important from their perspective was their levels of motivation to deliver that intervention. And this was compounded by the clinic context. So for example, healthcare workers' opportunity to deliver the intervention as we had planned, because they were, a patient burden was a huge thing. The infrastructure was not always conducive of providing, face-to-face individual support. And so these were the main, findings from that work. Then I went on and did my doctoral as a follow-up study to understand this a little bit more. And in that work, I had to develop a scale to explore what was being delivered in the intervention and how was it being delivered. So that was it was kind of fundamental in understanding what were the differences in those clinics where quit rates were higher compared to those where quit rates were lower. And we found that the way the intervention was delivered, so, the quality of the delivery of the intervention, where it was higher or better in the, patient-provider sessions, the quit rates were doubled. And so what do you mean by quality? I would describe it as the way the intervention was communicated to the patient. So how useful it was in engaging the patient with the targeted behavior change, which was to quit smoking. So this work now I'm talking about is, in 2013, 2016 time. After that, we got this Horizon 2020 grant to implement tobacco cessation further within TB programs in 3 countries, so Bangladesh, Pakistan, and Nepal. And this was an effectiveness implementation hybrid study, which recruited around 2,500 patients, TB patients. And we took all of the lessons that were learned from the past 5-6 years and did a lot more quantitative and qualitative work to understand the context, this time the contextual barriers in the routine healthcare for delivering a smoking cessation intervention. And I've just put up some of these papers, and I know Mariam is in the group too. She did a lot of work in this study in exploring all of this. And after transferring our experience, we ended up shortening the intervention from 30-40 minutes in the previous studies to just 10 minutes. And it was embedded within TB counseling because of the structural barriers and the patient burden. The providers just did not have the time for a longer intervention. And we were still able to achieve 29% quit rates at 12 months, which was remarkable. I would say, though, in a lot of the qualitative work that happened alongside in the study, it helped us understand that designing behavioral interventions for new contexts involved additional training on patient rapport building and moving away from didactic styles of, delivering interventions to more interactive approaches. And so I'm just going to go to the next slide and just finish off with the key message that I want to give here is there is a lot of, area and scope for future research in low and middle income countries. And what has worked for us is simplifying the content of behavioral tobacco treatments when we are integrating them within healthcare systems and keeping our training focus on patient engagement. So by developing core competency trainings in treatment delivery, by promoting treatment delivery approaches that enhance patient communication, and importantly, matching provider attributes and roles to the specified treatment. So I want to end with saying that interventions that work in one context might not work in another, or it might work differently in other contexts. So context is really important. It matters. For smoking cessation, we went through a cyclical series of adaptation work to integrate it within TB programs. And the biggest contextual challenge, I think, for us that we understood in a cycle is that adaptation of a counseling intervention that was developed for delivery by cessation advisors, well-trained in patient communication in England, to healthcare facilitators who were TB DOTS facilitators in LMICs, was a big change. It was a very different context. The resource drop meant less opportunities for ongoing learning and skills development for providers in these settings, less supportive supervision and the feedback loop, compounded with high patient burden and inadequate infrastructure. So this, I just wanted to show you the framework, the MRC's updated framework, and you can see that their core elements now includes context. So you have to consider context at all stages of intervention development, testing, evaluation, and implementation. And this is my core message, that start looking at the context from the very beginning of any project. If you want to understand how your theory or program theory is going to work there. So that is all from me. Thank you so much for listening.
Amazing. Thank you so much, Amara. And make sure the slides are shared afterwards, so all those references are available to everybody. So I think, again, if you've got questions or thoughts or reflections, please pop them in the chat. But in the meantime, we'll move straight on to our midnight researcher, Rima. I've got your slides again, but I think you were planning to share yours. Is that right? Oh, just on mute. Brilliant. So we are going from smoking cessation in TB programs in Pakistan, now moving over to phone-based interventions in Lebanon. Thank you so much.
So thank you so much, Izzy, for inviting me to speak to this audience. It's great to be among everyone and the larger group that joined before. And great to hear Omar talk about this amount of work that's happened on tobacco cessation. I've been working on tobacco control policy evaluation, mostly implementation evaluation, for a while on various tobacco control policies. And I have my first project working on cessation and integrating them in primary healthcare centers. So there's a lot to learn, Omar, from your group. So happy to have joined this to share, but also to learn. I chose to speak today about one of those projects, which is a phone-enabled implementation of cessation support in Lebanon, which is a grant funded by NCI. Dr. Ramzi Saloom, my colleague in the University of Florida, and myself are leading. Including researchers, of course, a large team from the American University of Beirut, where the work is taking place, but other universities also participating as investigators on the project. But just a little bit of background on the context in Lebanon. It's a context where there is very high tobacco use, very high cigarette tobacco use among adults and youth, and also very high use of an alternative tobacco product, which is water pipe tobacco. It's high among younger age groups and increasingly among women and men. And the latest survey that we conducted was that there was 39% adults smoking water pipe and 35% smoking cigarettes. This is within a context where it's high incidence of lung cancer among females, and it's the second highest among males. With a very weak tobacco control policy framework. So when we speak about context, we speak also about context at a policy level. So in Lebanon, although there is a strong tobacco control law that was passed in 2011, that law has issues with regards to implementation and enforcement, and thus important to think about a framework where smokers are living in an environment that's very enabling for tobacco use and not very encouraging for cessation. In terms of resources, there are also almost non-existent resources in the public for smoking cessation. And the least effort that has been put, or resources put, were towards that. And we have large network of primary healthcare centers that have strong non-communicable disease programs, but very weak in terms of having smoking cessation support. Although our work is emanating from a success story within one of the institutions that we work within, where there has been ongoing cessation services that served the community surrounding the universities, but also the public. And the point is learning from and expanding that experience to primary healthcare centers. So the goal of the project overall is to reduce tobacco use by developing a sustainable model for implementing an intervention on tobacco dependence in a low resource setting, such as the one that we're working with, within an existing health system that serves up to over 50% of the population in Lebanon. And we are looking at evaluating effectiveness of a multi-component intervention to implement tobacco treatment in this national system of primary health care centers. More specifically, so this is a project that has just commenced, so will not be giving details, but we are now in the phase of the first aim, which looked at understanding context to adapt and tailor the current existing smoke cessation program, but specifically to deliver it as a phone-based counseling program to adults. And later on, moving forward to test the effectiveness and cost effectiveness of a referral-based program that delivers smoking cessation to primary care patients, and looking at what the determinants are for implementation and sustainability. As a main partner with us is the Ministry of Public Health and the Department of Primary Healthcare Centers. So it's a multi-level intervention with components at different levels, thinking about what are the issues at level of the clinic, at the level of the provider, and the level of the patient, and what components can be integrated in the various intervention arms in terms of whether provider training is going to be needed, what are the educational materials that need to be adapted, how is the intervention going to be tailored to become a phone counseling intervention. So we have thought about a framework we can address the various contextual factors from at the health system level. So we're working with they call them focal points in each of the centers at the primary healthcare center. We're thinking about, within the context of the clinic itself, what are the characteristics that will ensure fidelity. We have adaptations that are contextualized so that we can sustain the intervention. At the provider level, what are the characteristics of the provider, their level, their knowledge of on cessation, but also their attitudes and beliefs, and finally the patients and their dependence levels, prior quit attempts, etc. And then finally assessing smoking abstinence within 6 months. So we have initiated our sort of relationship, which we would like for it to be a long-term relationship with directors of the primary healthcare centers. This is a recent meeting that happened in May in Lebanon, that brought together the primary healthcare center directors to explain to them the goals of the project and engage them and motivate them to engage the public health and the providers, both the doctors and the nurses within the centers. What I would be talking about in more detail is AIM 1, which is currently currently is being conducted, and the component of adapting and tailoring the intervention to the context. We have just completed conducting focus groups with 8 focus groups with smokers of cigarettes, but also smokers of water pipe, because cessation support will have to be also tailored for this mode of smoking. And we are currently looking at the data, and from the focus group discussions, we have started and planning to conduct in-depth interviews with the providers, and have initiated also direct observation within those centers of workflows and to understand how to integrate the intervention within the primary healthcare center among all the other activities and tasks and responsibilities that providers, both nurses and doctors, have to work within that context. But interestingly, now with just initial findings from the focus groups, we've learned that, and we sort of predicted that because of knowledge of the policy context, that mainly what smokers are saying as a main challenge is the weak tobacco control policy framework, and that in fact the findings reflect what those qualitative findings and feedback from smokers reflect what the data tells us, is that there's always very low motivation to quit, and willingness to quit. So it's a matter of how do we tailor the intervention to provide that strategy that will ensure the willingness of participants to engage in a smoking cessation program. In addition to findings with regards to the overburdened the healthcare system within. So I don't know if any of you are familiar with what's happening currently in Lebanon, but the context of tobacco control, policy, regulation, implementation, prevention always has been hard due to several reasons, but more recently, in the past 3 or 4 years, Lebanon is under has been going through a strong economic basically collapse of the system. And so those very weak healthcare centers or primary healthcare centers who were originally working within very little resources are now even more overburdened. And this might provide issues at how much providers and the healthcare workers can give capacity to support the intervention. And then finally, I mentioned the issue of low interest in quitting, and then there was interest in, phone-enabled support, but also contextually relevant feedback with regards to people wanting more, rather than phone, but wanting more face-to-face, more video kind of support via smoking cessation support rather than just via the phone. So they wanted a more personal, to add a more personal sort of approach to how cessation support is delivered. So we are currently going through that and trying to understand findings from the focus group discussion to think how to adapt the intervention before we actually start with our second aim of the project. So I will stop here and thank everybody for listening to me.
Amazing.
And
thank you so much, Rima.
Thank you, Izzy. Thank you.
Not at all. So we've got some time left in the panel. We've had to rearrange a little bit. I think one of our earlier speakers went over. But we've still got time to chat about the Eastern Mediterranean region. We've heard some experiences here from Pakistan and from Lebanon, mostly around tobacco control, so lung cancers and other respiratory diseases. But I'd just like to open it up and see who else is there. I see we've got Mariam, we've got Louisa, William and Peter in there. What are your experiences of working in the Eastern Mediterranean region? Is it unique? Is it particularly different when we're trying to understand context, or can we learn from other regions as well? Rima, do you want to take that on and have a think?
I think context. I don't think. Challenges might be unique to the context, but you could have common challenges across regions too, and so it is important to learn from experiences from within, but I think learning also from experiences and challenges and how challenges were used to adapt interventions from other regions is also very valuable. Not always to think, that if this has not been conducted within our region or within our country, that there is no learning to happen from experiences from other countries, and by understanding our own context, we can think about, how are the strategies that are adopted in other regions, which ones are more appropriate for testing within our settings or not. And for this reason, I was happy to hear the work that Omara presented, although it was very specific with TB populations, but still, and so, it's important to learn of how the thinking developed among researchers of moving from one stage to the other to get to, from the larger view to the more specific view. That's helpful in seeing how this was done.
Amara, do you have any thoughts about that, about uniqueness or commonalities in this region and others?
Thank you, Izzy. Yes, I think that there is a commonality in the thinking process of implementation. So I would say that very much for us and our work, we came from from a mindset that an intervention that works, that is effective theoretically, will be easily adapted to another context. Not really understanding that how the context actually interacts with intervention components as well. So it's not just about taking something that works somewhere else and then just adapting it to the context loosely. It was more than that. We had to actually pull the intervention apart, everything apart, and then redesign it in a way that would work for that population and for that setting. And even still, I mean, after all these years, we are trying to grapple with the differences in the healthcare workforce in that country or in those countries. So this is not just Pakistan, it's Bangladesh, Nepal, Pakistan, India, where the healthcare system is very different from the UK at least. And the resource that's put into, for example, smoking cessation advisors here, and the kind of trainings they go through, and how even their curriculums at undergraduate level have patient communication included in it. We don't have it in those countries. So these are small concepts which are not part of the intervention package. We just take the package and adapt it to another context, not really understanding that the people who are delivering it just don't have that skill or expertise. And so I think that is something that I'm really keen on working more in the future. That is this, much more than the intervention itself that works in some context, and how do you make it work for the people, and how do you develop it with them? So I think that is a commonality wherever, for example, in low and middle income countries, resource will always be limited compared to contexts where these interventions do work. So I think that is a common thing that people should consider. And obviously, whenever you are starting an intervention or starting a new project, it is with the stakeholders, with the consumers, the patients, that you have to start working with from the start. I think that's my take-home message.
No, it's super interesting, and I think you picked up on a few interesting points there, building this, of particularly around like resources and working with patients. And it sounds like working with those patients and beneficiaries is kind of like a non-negotiable, like that needs to happen as part of context assessment and understanding. But when those resources are limited, how do you prioritize what you assess as part of your context and what you don't? Because presumably you could do everything and spend all of the money, but we don't have that. So this may not be possible to answer this question, but any thoughts, Amara and Rima, that you have on that, and anyone else who can solve this crisis, please put your notes in the chat.
I don't think we'll ever solve the crisis, but there's a lot of learning. I think we can go on learning, and I can share from our projects. And I think Mariam would know a lot more because she's worked at the grassroots level. But yeah, I think you have to prioritize what is the need of the system. So for our smoking cessation intervention, it was the TB program itself, so the stakeholders and the political will from the program to integrate smoking cessation, that was key. So we had to work with them. The other important factor is the people who are delivering the intervention, who are taking out the time. So we started with the 30 to 40-minute intervention, which was just not practical. With the patient burden, I mean, some of the clinics have like 200 patients in a day. So counseling them individually 30 to 40 minutes just cannot happen. So we had to reduce it and embed it within TB counseling, because that was the job of TB DOT facilitators. Smoking cessation was not their job. So it won't be sustainable. So I mean, they're small things. So we had to work with the providers, with the program itself, but also with the patients. I mean, these are not general population. These are TB patients. They're sick. They don't have that much time. They cannot sit for too long. So we had to kind of make it in a way that they still get the message that's important to them in the shortest, most optimized way.
Great. Yeah. And Rima, what are your thoughts if you have to prioritize certain aspects of context assessment?
Yeah, I agree with Omara. I would definitely not keep patients out. I mean, I would start with patients, move to providers, and then if resources are an issue, go beyond that and try to understand context beyond that. But I think what's important also is key here is flexibility and the strong heart of researchers to think about, this is an intervention that's evidence-based. I'm going to break it up and I'm going to take feedback and the knowledge from the patients, from the providers, and from other levels within the context and adapt it. And that requires flexibility from the part of researchers, and having, the willingness to incorporate all these issues that come up through their evaluation from the stakeholders and from the patients.
Thank you. It's been so interesting, and I know that the rooms are going to be closing very shortly, so we can hear from a few different ones as well. But it's been great to have you, Amara and Rima. I know it's we keep saying it, but good Lord, it's early for you. So thank you for joining us and presenting.
Thank you.
And I know we've been a small but mighty group today, so it's always nice to find out who else is interested in working in the Eastern Mediterranean region. So I think the rooms will close shortly, but if you've got any particular resources or anything you think is interesting, particularly with this region, please do share it in the chat. I know that the WHO have got their own bulletin for this region. They did something fairly recently around tobacco control, but also with other NCDs. Please do get those in there. So I think whenever you're ready, we can head back into the main room. And
GACD team for this opportunity for us to speak about the Access Cancer Care India project. My name is Aruna, and I work at the International Agency for Research on Cancer. And I'm speaking on behalf of the ACI consortium today. I'd like to start off by giving a little bit of a context of where we're at in terms of the project and our objectives per se. So the whole idea of the ACI project is to design and evaluate a new multi-level strategy that's actually integrated and contextualized to the local health system, and to essentially improve access to early detection of oral, breast, and cervical cancers among rural population in India. And this implementation research focuses on 3 states in India, which is 2 southern states, Kerala and Tamil Nadu, and 1 northern state in Rajasthan, which provides very different but somewhat comparative implementation ecosystems. And we're hoping to dissect critical issues and barriers, political, whether it's socioeconomic or logistical issues and barriers, which will eventually, we hope, to support national scale up and inform other comparable states or regions globally. Like I mentioned, the intervention targets 3 site-specific cancers: oral, cervical, and breast. I would like to go through what our essential work packages are, and I'll let you know what are some of our experiences in terms of where we're at in terms of the project right now. So essentially, the whole project is divided into 6 work packages, and I'd like to somewhat split it into 2. One is the phase 1, which is more of a contextual assessment, which will eventually help us design the interventions that we will implement in the phase 2, which is work package 4, 5, and 6. My presentation today will focus on that box that I've highlighted, which is phase 1, which is essentially where we are at the project. We are at very, very early stages, where we've started off with a stakeholder engagement process in each of the 3 pilot sites. We will go a little, the next stage is we're going to go and assess contextual factors or the barrier assessments, and then look into the capacity assessment in the 3 states to see what is the system readiness to implement the interventions that we are thinking of. Now, at the very early stages, we've started engaging our stakeholders, and we think that's a very important learning. We started off via a mapping process, a comprehensive mapping process for the 3 different states and the 3 different regions, mapping out their power, their interest, and influence in our project. And the second thing that we would be looking at in the phase one is to what are the barriers and opportunities that exist throughout the care continuum for cancer. While our project focuses on early detection, it was very important for us to look at the entire continuum, starting from in a asymptomatic general population, what are the screen delays? Secondly, what are the access delays for those who are symptomatic for cancers? What are the diagnosis, treatment, and eventually treatment delays? And we want to do this looking into different perspectives of users of the health system, whether they're service users, whether they're service providers, or from the health system perspectives. For this, we needed to develop different tools targeting the different population. For example, we needed to develop tools that looked into the pathway of a patient who has already developed cancer who is now at diagnostic stage. We have developed tools that target general population to look into what are the barriers and opportunities that they have to access screening and diagnostics care. We're looking into tools that target service providers to see what are their perspective on what are the barriers and opportunities that access. And the next stage that we are doing right now is to look into the current policy analysis and the health system's readiness and the implementation climate. And we're doing this through not just desk reviews, but we will be visiting the facilities, and we needed tools to assess those facilities for different sort of categories per se. And we will be talking to the key informants who are involved in the current organization or service delivery. And with all this information, we hope to break them down into the different health system building blocks, looking into what are the strengths, weaknesses, opportunities, and threats that exist. Next, the one thing that I mentioned earlier is we hope to design a multi-level intervention strategy. We did not go into this project thinking about a certain intervention that we already wanted to implement in the 3 states, but we went with an open mind to find out what is already in the 3 states. And we hope to triangulate the findings that we find from this phase 1 that we're currently in to then feed into that intervention. We hope to present this intervention to the stakeholders who we've started to sort of map out and collaboratively identify an intervention element that will eventually be best fit into the local context. We don't anticipate that we will receive or we will implement similar intervention even in the 3 states. We aim to design site-specific implementation tools for implementation, the protocols, the implementation, and the training protocols, and hope to integrate them into the existing health system. Now, even at this stage, where we're very early in the project, I'd like to highlight some of our key takeaways. Starting off with existing tools, we felt that this was very important for the project that we're looking into currently. There are already a lot of existing tools that are out there, whether they're published or not. So we did not start from scratch. We did a little bit of homework to see what is already there and adapt them for our use. And we used a participatory approach in developing the tools and involved our stakeholders. We got input from our stakeholders even throughout the development process to ensure that these tools were somewhat relevant and user-friendly. And while this might not be feasible in a lot of settings, we ensured that we pilot tested these tools with a small group of users in the different settings before we're aiming to even scale them up for wider use. And this helped us identify any problems that existed within the tools to ensure that they're effective. The one thing that I felt that we did not consider is the preparatory phase that took longer time than anticipated. I think that moving forward for future projects, that we have to realize that if we're going to take a participatory approach, even at this stage, phase one, where we want to involve our stakeholders and get input into setting the stage to be what will the intervention be, we have to consider the time that will take. For our project, even at regulatory approvals at the local sites took time, and the tool development, because we started using a participatory approach and not took some validated tool that was already there, that took time. So even as we are preparing to train and roll out these tools, we realize that there are some changes that need to be made, as, for example, implementation guidelines, local or national implementation guidelines change. So now we need to go back to the table and then look into what changes we need to make to our tools that we've already developed because of the local changes in the region and the country. So the key takeaway for us is we need it to be flexible, we need it to be open to feedback. And again, the one thing that I would like to emphasize here is that collaboration with the local project team was very key. I did see that two of my colleagues from the project teams are here today, and this was very important even for us to involve these key stakeholders, and their work within the local sites was vital for us even at this phase. I'd like to stop there.
Did anybody have any questions for Aruna?
My colleagues, Ishu and I think Anjana from the different sites are here as well. Maybe Ishu and Anjana, if you'd like to share some of your experiences with engaging the stakeholders. And
that would be great. And then I see Mercy and Daniel has also got a hand up.
Yeah.
Sure, I'm happy to do that. I think one of the things that we realized while we were doing the stakeholder mapping and engagement, and as Aruna explained that we have 3 sites, what we noticed that at each of the sites, there was a lot of variability because of the context of who were the key stakeholders. So for example, there was one category of stakeholders that was very important for one site, and we would not see the similar pattern on the other side. So I think that was one of the key learnings that we realized, where the key stakeholders vary according to context. And the second thing is that the stakeholder engagement that we are sort of we've begun and are wanting to weave into our whole program involves sort of different levels of engagement at different stages of the project. Some stakeholders are easier to manage than the others. For some, we anticipated a set number of sort of hours or time that will be sort of needed to engage with them, for example, to get permissions for some level of implementation research, but it's taking long, people get transferred. So those are the things that I would say that we've learned and that need to be built in the project timeline, because those are sort of things that you don't know are going to happen for sure, but something that you can anticipate. I'll hand it over to Anjana to see if she has anything else to add, and then we can go to the question.
Thanks, Ishu. Hi, this is Dr. Anjana, and I am from Karkinos Healthcare. It's Kochi, Kerala-based healthcare private company. So we are one of the sites. Karkinos is one of the sites in Kerala, which is involved in this project. So as Ishu was mentioning that in the stakeholder engagement process, one of the challenges that we are currently facing is that working with the public sector and getting the approvals from them, which is taking a bit longer time than expected, so which needs to be considered in the timeline. And the other one, which also I have to mention, needs to be considered during the whole process, is that the paperwork that requires, because it's a global project. So we some of the paperwork involved also takes longer time than what we anticipated. So things are falling in place now, and hopefully we are almost there on the work package too, and we hope to do the process well. Thanks. Over to you, Arun.
Just first of all, thank you very much for also giving me this opportunity to contribute to this workshop today. So my name is Cindy Pardoel, and currently I'm a PhD student within the Scaling Up NCD Interventions in Southeast Asia project, the Sunny Sea project. And hopefully I still have some time left, but I will tell you a little bit more about, well, more of a specific, can you go back, please? Sorry. A topic that we worked on about the cultural sensitive community capacity building for prevention and control of non-communicable diseases in Southeast Asia. And why is this topic of importance? Well, next slide, please. We, of course, already had a lot of information already before this breakout rooms. But well, in Southeast Asia, they have a lot of community-based programs, which are mainly aimed at, well, different various aims, but social activities, cultural activities, also financial promotion, so giving loans to people. But commonly, they also have some kind of health aspect into it. So this could be screening for non-communicable diseases, but it could also be physical activities to promote healthy behavior. So aiming to reduce these health risk behaviors. And well, we know from literature that it's and as we said before, that context is really important, and that these community-based programs can promote health more effectively when they are adapted to the culture and context in which it's implemented. But what we found is that in the literature, and we were really looking for a guideline for the projects that we worked in, is that a really practical and scientifically based a guideline for Southeast Asia was lacking. So what our objective was within this, well, kind of a sub-project in the bigger project, was to develop the guideline for, well, for this adaptation. And we did this in two stages. First of all, we developed a checklist, and we did that based on the conceptual framework of positive health, in which I will elaborate a little bit more in the next slide. And we use this to look into the literature. And then the second part, we also developed a guideline, and I will talk a little bit more about that later on as well. So the theoretical framework that we used, the positive health framework, maybe a lot of you already know it, but as you can see, well, health is more than just the absence of the disease. Health is also the well-being of a person, and you have multiple dimensions that, well, that contribute or that makes your health what it is, but also brings about the perception of health that people have. So looking at bodily functioning, mental well-being, meaningfulness, quality of life, daily functioning, and participation. And all these different dimensions, they well, come about in different contexts, right? In the cultural context, in the social context, in the demographic context, and in the healthcare context. So well, using this framework really helped us to map these cultural and contextual aspects that were well, of interest looking into these programs in Southeast Asia. Next slide, please. And I will not go into them all, but I just wanted to give some idea of what we found in the literature. looking at this perception of health within these different dimensions. So first of all, looking at mental well-being. Well, we know in Southeast Asia that emotional expression is commonly considered as a personal weakness. Not everywhere, but in a lot of regions it is. And this can really contribute to the stigmatization of mental illnesses. So when you're developing an intervention, or when you're maybe transferring a program to another area, to another target group, to another country, maybe, it's really important that, well, the stigmatization of mental health is identified if it's there, and it should be, well, part of the program then to discuss it as well. Looking at psychological stress sources in Southeast Asia, there's a large number of persons that are exposed to extreme stressors, and this could be due to different crises, mainly natural disasters, and therefore this can really have an impact, of course, on a community, but also on a person's life. So it's really important to also look into these stress sources. And then going to the next one, so the meaningfulness. Oh, sorry, no, next, yeah, thank you. The religious and spiritual beliefs that are really aspects that can give meaning in life. And if we look at Southeast Asia, often it's a multicultural region with a variety of religions. And it's really important to, in these communities, to, well, have these religious and spiritual beliefs, well, in mind. And this could be, for example, traditional medicine or traditional healers. When talking about non-communicable diseases, for example, and in a community, like screening for them, and talking about taking medicine, it's really important to know if there's a belief in this traditional medicine, and this can really impact the outcome of well, these health promotion activities. And the last one I want to give an example of is the participation. So in Southeast Asia, there's a high intergenerational co-residence. So often children take care of their parents, and the older people really participate mainly by giving advice to the family. So it's really important that, well, to look into family structures and to look into if people are able to really participate in having their family role and participating in the usual family activities. I see we only have 5 minutes left, so I will go on to the next slide, please. So in the next step, what we did is we developed a guideline for really using this checklist for when developing or when transferring a community-based program. And we pilot tested this, and we did this in collaboration with local stakeholders, but also experts from all over the world. So not only Southeast Asia, but we also looked further on beyond Southeast Asia, and we pilot tested it in Vietnam and in Indonesia. And well, what we found was that it really gives insight in culture and context, and it's especially useful when developing a new program, as I said, or when it's implementing in another area, especially with other target users. 2 quotes from 2 people that were involved. So implementing a training in a rural area and then in an urban area, there are differences between the target groups. And with the guideline, we revised the training to make it more fitting with the local context. And this can also be really helpful when a training is adopted in another country. And then from a participant from the Philippines, who said the guideline can be used broader, not only for health focus or topics, for example, disaster reduction. It should be like also cultural and context sensitive. And often we use or reference to materials from other countries, and then we forget that we have a different context and a different culture. So next slide, please. I had to do it really quick. Well, for the feeling, hopefully I could give some insight of what we worked on. Thank you very much. And if there are any questions or any topics you want to elaborate on more, you can also send me an email, because I don't think there's time anymore to really have questions right now. Thank you.
Thank you so much, Cindy, and well done with the technical issues and getting back on track. Really great to hear about what you've been doing, and particularly with community-based programs, there are so many contextual factors to explore, and interesting to see you emphasising the mental health as part of that as well. I think we'll just have a couple of minutes before we're going back into the main room. So if anybody has any questions. We have a question that's come in the chat. How do you ensure stakeholder participation? Any tips you would like to share?
I can perhaps take that one, Margaret, very quickly. I think the one thing that we realized when we engaged our stakeholders, it's very important to also consider the stakeholders' perspective to our project, and it shouldn't just be one way. And I think when we think about stakeholder engagement, the one thing is we've got to think about what's in it for them to participate in your project. For example, we obviously as researchers have our aim or objective that we want to reach, but when we look into stakeholders,
very much, and to all. I hope I will entice you with the presentation this afternoon. Pacific greetings coming all the way from Fiji. So this is a scale-up food policy interventions to use NTDs in the Pacific. Okay, so yeah, we aim to evaluate the impact and process of implementation of effective food-related policies to reduce salt and sugar consumption in Fiji. And then we also, the project is designed to in a number of ways. The first one, we repeat sectional nutrition service to try and monitor food sources and food intake. There was policy analysis done to help us understand the context and opportunities for scale-up. So in this one, we interviewed policymakers across governments, as well as representatives from CSOs. We did a modeling impact and cost effectiveness of interventions to evaluate the impact, processes, and cost effectiveness of implementing chosen food policies. And we also engage with policymakers and other stakeholders to strengthen the implementation of government food policies and the comprehensive impact of process evaluation. So I'll be taking you through some of the work we've done and share some strengths and challenges as well. So with this particular slide, I just want to reiterate the importance of transferable skills for the researchers. In all projects that are conducted in the Pacific, in Fiji, we value building a local capacity. So especially with research and domains that I am sure all familiar with are very important in taking through early researches, especially with transferable skills. Let's move on to the next slide. So I will just share with you strength. Before there is two challenges that I would like to share. Firstly, is the support of the government's Bureau of Stats. Our Bureau of Statistics usually supports in pre-studies in previous governments, whereby they would be providing, helping us with in identifying the places where we can collect our data from. But this particular GACD project, we, the government of the is got a different ball altogether, so they do not allow us to use the data from the Bureau of Stats, which means that we have to go out and do a community listing. And the other challenges we went through was really one of the objectives that we would like to use is with the no translation or sticky project was not able to be, were not able to conduct because of the turnover of the government. And the new leader wanted us to make another new agreement. We think it's a waste of time for only 1 year left. But that doesn't stop us from working around the government and the government system. So the strength in the study and the policy environment is really the collaboration between the 4 universities across Australia, with the George Institute for Global Health, the Deakin University, and University of Sydney, as well as the technical support from the government and partner organizations, including the Fijian Agriculture Organization, WHO, World Bank, and others. The funding from GACD of Australia, so we was very lucky to be supported by the government of Australia, and the ethics that was provided both from UNSW and Fiji National University. So of course we use a whole of government approach and commitment to NCD prevention and nutrition. And looking at some of the work that already been done with the Ministry of Health, they have 3 policies for NCDs: nutrition and food security and wellness. Ministry of Agriculture is a key actor for improved nutrition and diet quality. The Education Ministry has got nutrition in its curriculum, although there is a lot of scaling up that needs to be done with these 3 government ministries, and not to mention the Ministry of Trade as well. And there's excise taxes on unhealthy food and beverages, including those and subsidize also subsidies also in vegetables. So although we have the government policies that are mentioned here, is a lot of there's a need for scaling up. So the first innovation I'm will be sharing this afternoon is community engagement and ownership. So looking from the top down and bottom up approach, we're looking at the social cultural systems. All researches that we do, we make sure that it's aligned with the government and the research protocol. With the formal collaboration is important because firstly, the ethics processes requires endorsement from the heads of the facilities involved in data collection. So with our study, because it involves the communities, we need to consult with the institutions that are involved, which is the Ministry of Itaukei or Indigenous Affairs, and the Ministry of Local Government, Housing and Environment. So get this facility approval is it's a lot of time, but it is important that when we engage, before we engage with the community, we need to get the endorsement from all these key people, key officers in the government. Not only there, but we all after getting the endorsement, we also did consultations with provincial officers and the village heads, and going down to the phase organizations, especially when we are working with settlements, formal settlements, that we have to go through advisory councillors as well as faith-based organizations where we can get through to the communities. And so at the end of the day, when data were collected, we also need to disseminate the results of our studies. So it was disseminated to stakeholders via conference. Infographics was disseminated, were distributed, as well as played its role in broadcasting it all over Fiji. So, forthcoming national NCD plan will provide an opportunity to further improve the alignment between health, agriculture, trade, education, and channel enforcement. It's important that when working with the government ministries, it is important that we work together with these government ministries, because we know in one of our last studies that most of the government ministries work in silo. So one of our main aim or success is the own. So at this time, we are still getting an invitation from the provincial offices for us to present into the community or in the provincial office. So they'll be able to buy in the results and disseminate that further to their communities or use it in their operational plans. The second thing that I'd like to share with you this afternoon is strengthening interdisciplinary partnership or stakeholders collaboration. We have the Alliance for Healthy Living in Fiji, and this was established in 2014, included the Consumer Council of Fiji, Diabetes Fiji, and the National Food and Nutrition Center within the Ministry of Health. And they partner with the Asset Research Center as well as with WHO. So the Alliance for Healthy Living hosted 3 consultative workshops to bring stakeholders together, including teachers, businesses, and faith-based organizations. And this enabled a consumer-led agenda and were critical in terms of showing that the Alliance rendered the aims of a range of states. Important for us to work across the community, so work across other organizations is key to being reach as well as reaching out to them in terms of the risk of our studies. So following the consultations, the Alliance ran advertisements about the negative health effects of sugar-sweetened beverage, and Ministry of Health provided promotion TV slots of this. One thing that I would also like to share here is that one of the other branch of study that we did following this one is a consumer-based survey, whereby we reach out to the policymakers and the community on what their perspectives on the available or policies that do exist in Fiji, especially health-related policies, whether they are aware and what they views and how they, what other areas would like to be scaled up. So with us, also some multilateral corporations and engagement, leading WHO Collaborating Center for Disease Prevention and Management, that is where the research is taking place. We work at WHO Collaborating Center for Population Salt Reduction with University of New South Wales, as well as the WHO Collaborating Center for Obesity Prevention at Deakin University. And of course, our center is also WHO Collaborating Center for Obesity Prevention. And we also provide technical advice in during WHO Western Pacific Regional Coordination Mechanism for NCDs, as well as contribute to the preparation for the UN Food Summit in November last year, whereby we kind of work with the TGI to ensure the indigenous as part of the led November 2020 UN Food Summit. And those are the key topics that were discussed in the committee food systems that were engaged with. So in summary, these are the key lessons or principles for working with partners. Like I said, building local research capacity is important. And we thank the funding from the GACD that help us in doing this. Mapping and strengthening networks is important. Networks, especially around local networks. Like I said, working across other sectors, not only government, as well as civil societies. Ongoing stakeholder consultation. This is a very key area that we took a lot of our time in trying to engage with the right stakeholders, right people in the communities. Strengthen research culture in government ministries. We've been asked by the Ministry of Health to always help or involve the staff from the Ministry of Health in our research, in all the research that we do. Build linkages with other relevant initiatives. And transparency in project model is very important, whereby we discuss the design of the work research that we did, and sustainability and joint ownership. At the end of the day, we would like the Ministry of Health and the community to own the project or own the program that comes out of our study. And lastly, the balance between perfect study design and feasibility, which it's very hard to strike the balance between that. And at the end of the day, it's a buy-in from the study that you are doing. Yeah? Most of the evidence is needed, of course. So, but they always look at how the study was designed and how it was delivered. And of course, the results that came out of the study would be something that the policymakers would be interested to buy. And that's from my side, to communities that will be said, as well as all those who support the project. Thank you very much.
Thank you so much, Nande. I think that was really excellent, really interesting to see some of the lessons learned, particularly about involving ministries, but also local stakeholders in your local community. I think in the interest of time, what we should do now is move on to David and Jenny. So Nande, if we could stop sharing, I've done that. So David and Jenny, if you want to go ahead now, and then everyone, if you've got any questions, save them all up and we'll try and answer as many as we can at the end. So David and Jenny, over to you.
Thank you so much for that. Caroline, you don't mind just leading with the presentation. I'll just say, please click very politely, of course, please click. And both Absolutely. Jenny and I worked on the presentation, but I'll be presenting it today. But don't you worry, Jenny's there in the background. If you have any hard questions, she's willing and prepared to take them. And we also have another colleague of ours in the room, Kylie Gwen, which, did come second in that quiz. I was a little disappointed, Kylie, you didn't make it to first. I was cheering you all along. Thank you so much. So thank you so much for the opportunity to come and talk to you today about the Breathe Easy, Walk Easy, Lungs for Life project. Before I begin, I would like to acknowledge the traditional custodians of the lands in which I join you from, the lands of the Gadigal people of the Eora Nation here in Sydney, and pay my respects to elders past, present and emerging, and those that are with us today. The presentation itself is around assessing the Aboriginal Australian context to support the implementation of the Be Well project. And as I said, Jenny and I worked on the presentation, and I'm kind of just presenting on behalf of the research partners, the Aboriginal Community Controlled Health Services that we've been working with over the last several years, as well as the investigating team, which are mentioned underneath the picture. Thank you. So the presentation itself is obviously framed around the Breathe Easy, Walk Easy, Lungs for Life project, which is around building Aboriginal Community Controlled Health Services capacity to deliver pulmonary rehabilitation for the management of chronic obstructive pulmonary disease. So when we were thinking about the way in which we were going to design the presentation, what we wanted to do was obviously do something that was obviously of interest for us, but probably more interest for you. And so we've decided to frame it around the cultural context that we've done, just because we want this to be a benefit for everyone in the audience, not just those who may be working on an Aboriginal lung health project. And so the presentation itself will talk about the context of Aboriginal Community Controlled Health Services, the Aboriginal cultural community and health research context, talk about how we've gone about assessing and responding to this context, the role and of the importance of a team of Aboriginal health workers, and just a couple of lessons that we've learned. Thank you. So the Be Well project is funded through the National Health and Medical Research Council of Australia through the Global Alliance of Chronic Diseases. The implementation science framework that it uses are the REAIM framework, which Paul Vicky mentioned, as well as the framework that's in front of you, which is the knowledge to action cycle. The cycle itself, if you look at the centre of the diagram, talks about existing knowledges. So we know that we've got first level knowledge about how to deliver pulmonary rehabilitation for mainstream Australia. so Aboriginal, non-Aboriginal people, but more so in public health services who are predominantly non-Aboriginal. We've got COPDX guidelines and pulmonary rehabilitation guidelines, and we also have a wealth of knowledge around Aboriginal culture, as well as a history of Aboriginal health service delivery. And we are attempting to apply that to the issue, which is the high incidence of COPD for Aboriginal people, high rates of hospitalisations, limited access to best practice management for chronic obstructive pulmonary disease for Aboriginal people in Australia. And we really want to evaluate the implementation and the impact of pulmonary rehabilitation within culturally safe Aboriginal community controlled health services. And so we've been working with 4 sites around New South Wales to look at how do we adapt pulmonary rehabilitation to best fit this context. Thank you. So I'm aware that some of you might not know what an Aboriginal community controlled health service is. And so I just want to give you just a bit of a background or context of the context. So these services are integrated organisations which are governed by boards who consist of Aboriginal people of the local community. They were established to address the inadequacies of the public health service to deliver culturally safe care for Aboriginal people. Pictured here is the Redfern Aboriginal Medical Service, which was the first service to be established in Australia in 1971. And Aboriginal community controlled health services deliver holistic primary care in really dynamic, fast-moving environments. They deliver care in innovative ways, responding to local health priorities governed by Aboriginal culture. And so these services are the cultural interface between Western medical service delivery and Aboriginal community ways of knowing, being and doing. Thank you, Carolyn. So when I'm talking about Aboriginal culture and community, I'm talking about contemporary Aboriginal culture, you know, very much guided by family, community, land, and language, with an emphasis on respect for elders, sharing and community, caring for others, caring and having respect for country, and working in ways that honour Aboriginal knowledges, systems and protocols to effectively engage and be of service to our knowledge holders and community broadly. Thank you. Within Australia, Aboriginal people have high levels of chronic disease as a consequence of colonisation, and there is a history of exclusion of Aboriginal ways of knowing, being, doing within research practice and academic institutions, and research in the past that has been poorly aligned to Aboriginal people's goals, values and voices, with an absence of co-design and strong community engagement. Though there is a new era of Aboriginal health research with stronger alignment to Aboriginal research ethics and guidelines, approaches that not only value but respect Aboriginal worldviews and paradigms. There's been an increase in Aboriginal-led research initiatives and a focus on reflexive allyship with non-Aboriginal researchers, which is allowing the space to be transformed to avoid replicating harmful colonial practices, with a stronger commitment to co-design and partnerships through the application of strength-based approaches to issues that communities wish to address, and of research that privileges Aboriginal voices and respecting self-determination and management and building local research capacity. So I am one of the Aboriginal researchers within the Be Well project, and I suppose this isn't so much about me, but you know, Aboriginal researchers have been so crucial in many research projects, and you know, they've been crucial in establishing relationships and building trust, engaging respectfully to seek to understand from a community perspective, to advocate for power sharing, applying the principles of co-design, and where needed to reorientate the intervention to best suit community, and to ensure that as research partners that we're working hand in hand as true partners, that we're allowing community to lead the way, and so there is nothing about us without us. In terms of assessing and responding to the cultural context, so as you could tell from that slide earlier, we were really about better understanding how to implement culturally safe pulmonary rehabilitation within the context of Aboriginal community controlled health services and Aboriginal community. And so during implementation, there were opportunities to reflect on our perceptions of the context, of this cultural community context during site visits, particularly through the Aboriginal staff and community lens, to really start testing that knowledge. So that was that triangle in the middle of the knowledge to action framework. And what we realised is that changes were needed to the initial proposal just to enable the project to more effectively respond, align, and to reorientate itself to the Aboriginal context. And so what this meant practically was we had to include community awareness days. So this is because there was limited understanding and knowledge of chronic obstructive pulmonary disease and what this pulmonary rehabilitation, this exercise program and assessments were all about. And it really provided an opportunity for our team to work on the ground and to conduct community consultation, to do case finding, to really understand how they wanted the programs designed and implemented. There was another challenge for us where we needed to explore the experience of care. There hadn't been much research, if any, around an Aboriginal person's journey in regards to COPD. And so we have completed a handful of interviews just to understand how that space is different and what has been their experience of care, from diagnosis to ongoing management to sharing their diagnosis with their families and understanding the broader community context. In addition, we were also needed to kind of really explore how we were trying to build workforce capability. And so what we implemented with the staff of those services was an online education program to train Aboriginal health workers, exercise physiologists and physiotherapists using Aboriginal pedagogy and co-design principles to develop yarning education material to support the education component of pulmonary rehabilitation. So within pulmonary rehabilitation, you've got exercise training, and the other side is building knowledge and education capacity. And so that's what we did. The other thing that we had to do, that we realised that we needed to do, was to understand the much broader context. We're only working with 4 Aboriginal medical services, and so within New South Wales, there's about, well, I think there's about 48. And so what we've attempted to do is to do a statewide service mapping, looking at workforce, infrastructure and service needs in relation to chronic obstructive pulmonary disease and pulmonary rehabilitation. And so we're at the final stages of that, just about to begin some data analysis. In terms of the lessons learned, so obviously effective assessment of the cultural context requires time and reflection on our perspective, so that we have clarity, that we're able to read and understand and interpret the landscape effectively. Within our project, we've understood the importance of the inclusion of an Aboriginal elder and a team of Aboriginal researchers to function to ensure that we are responsible of our cultural responsibility, obligation and advocacy that we are performing in this space. And this has required a supportive a chief investigator, thanks, shout out to Jenny, as well as a really important and great investigating team more broadly that not only value but respect Aboriginal ways of doing, that allow us to practice with cultural humility and respect and to be flexible. And I suppose a bit of a lesson for GACD is, how crucial it is to fund projects that incorporate and value Aboriginal knowledges, methodologies and Aboriginal researchers, and how important it is to continue to strengthen mechanisms for cultural advice and support, not just within our own individually funded GACD projects, but across the organisation. Thank you.
That was absolutely fantastic. Really, really interesting, really exciting. I'd just like to say, yeah, amazing. I'm so, yeah, in awe of the work that all of you guys are doing. I think what I'd say is, if anyone's got any questions, please pop them up in the chat, or, stick your hands up, please do. But if I can just start off, I think it was really interesting to hear your opinion about the having the voice of the Aboriginal researchers, so getting that context there. But how also do you feel about, involving the voice of the patients on the ground and potentially involving those people in your kind of management team? Because I think that's a lesson we're learning more slowly in basic science, but I'm really interested to hear about how that is when you're actually implementing an intervention like this.
Yeah, it's so important, isn't it, about ensuring that the consumer voice is involved, from the get-go. And for our project, it really has been a learning lesson. We've got a reference group that we have that consists of community members, that consists of government organisation, of people in the policy space. But that's been some of the reasons why we've incorporated the awareness days and we incorporated the experience of care interviews, because there were assumptions that we were making based on mainstream Australia that didn't necessarily fit, didn't fit within a community orientation from Aboriginal people who are less concerned and focused on individual journeys, who are more interested in understanding the condition and see the condition as a community response almost. So it's been instrumental having a consumer voice. But I think, like all of us, when we think back to how we've conducted interventions, I think we could have done it better. And that we could have, I think, Jenny, you would agree, just that a greater engagement of consumers in particularly the co-design. I think there was a bit of an absence of co-design, particularly in establishing the intervention. And we understood what we understood from a mainstream environment, but it wasn't until we had real skin in the game on the ground, where we were talking and engaging with community, that we started to see a huge gap in what we thought and what their perspectives were. And we saw it not only an opportunity, but that we had an obligation to ensure that while we were there on the ground, that we could do as much as we could from the perspective of community. Jenny?
Yeah, look, I was just going to say that, when you're trying to get projects up and running, engagement with consumers is vital. We tried to also review the consumer view as to how they found the program, so that we can actually change it in the future. So it's like an iterative process, really, a bit like the CIFA that Paveki was talking about, is that, that's a constant cycle really in all this, and we learn all the time going around that cycle as to what we could do better. And, it'd be lovely to be funded for many, many years so we could keep that cycle going, because we're learning all the time, and every context is different. Even within those 4 Aboriginal medical services, each context was different, and we had to adapt to different ways that those services were run. So there's just a huge amount to learn. And I think Paveki really put it well, the complexity of context and how you manage to research in that complexity, but also write about it, so that people who understand, so people who are not in the area get to understand the nuances of complexity of context is really a key thing, which is not easy to get across when we're writing our research papers. Yeah.
Oh, thank you. I think that's kind of really outlining it to me. I was going to say we've only got a couple of minutes, so yeah. If you've got questions, I'm really sorry. It says G Gould, so go ahead.
Sorry, my camera's not working. Hi, David. I thought that was great. I'm just curious quickly to know, whether you finished your project and, whether you're in the writing up stage or what phase you're in. Just out of interest, see how you're running with that.
Sure, I'm in the panic stage, Gillian. I am absolutely at the panic stage. We finish, the project itself finishes its funding at the end of this year in December, so the 31st of December. And so we are in the middle of writing several papers. We've been really fortunate to collect a significant amount of data, and now we're just trying to position those papers to ensure that the work that we have done is of value for the Aboriginal community-controlled health sector more broadly, but also that I can get this PhD done and dusted. So that's kind of where we're up to.
I'd love to talk to you. I'd love to talk to you a little bit more about that, maybe offline, if that's okay, just to compare notes and perhaps get some ideas about how you're going with writing it up and how we're trying to write ours up, and just learn from what each other's journey is at the moment.
Absolutely, and maybe we can touch on some of that at the next Aboriginal population, the Indigenous population health working group. I think it's a really important space for us to kind of build our collective knowledge and our experiences together. But as you know, always happy to sit and chat with you. It's always a pleasure. Thank you.
Yeah, thank you.
Thank you all. I think we're going to close the breakout rooms now, but I just want to say how exciting and interesting that was, and great presentations. Thank you, Nando. Thank you, David. Thank you, everyone, for your contributions. It's been amazing.
Thank you.
Good. Hello, everyone. Welcome back to the main room. We don't know here where the time has gone. It's just flown. I hope that you had an opportunity to hear from the two speakers in your individual breakout rooms, and that you potentially had an opportunity to have some questions and discussion going on. But we apologize that it may have just gone, time has just flown. We've brought you back because we did ask 3 panelists to listen to the conversations and to the presentations as made. That's Mercy and Daniel, David Mahag, and Mariam Noor. And we thought it just in a very quick fire round, just to listen to hear if each of those had a reflection on what they were hearing in the particular regional breakout room. So I'm going to start with Mercian. What did you hear in your room?
So what I heard was that the preparatory phase takes a lot of time before the actual intervention starts. It's very important. And in fact, we published a paper where we put in the pre-operational challenges. So doing an implementation science research is really very tough. And this preparatory phase is extremely important to get the intervention right. So that came from Aruna's presentation. The other presentation brought in a few religious, cultural, spiritual aspects that are very important in understanding context. So few things in understanding context is very important, and those came out. So these are a few of my reflections. Thank you. Okay.
Excellent. Thank you for that, Mercian, and really nice, succinct response there. Mariam, I'm going to turn to you next. What did you take away from your room?
So from my room, that was Mediterranean region. One thing which was evident from both presentations, that policy should be the priority first. And then if we have to make any intervention successful, we have to work on the motivation of the intervention providers. In terms of maybe workload, training needs, the intervention must cater their training needs, and the intervention content must be developed according to the level of the intervention providers. And then thirdly, we also need to understand if the people for whom the intervention has been designed, the NCT is a priority or problem, or if they understand the importance of that thing as well.
Great. Thank you so much, Mariam. Again, a nice succinct insight from what was being shared and discussed in the room. David, finally you. We're making you work very hard today.
I know, tell me about it. Listen, I just want to let you know that obviously our session was the most exciting session. Both Nadi and I talked about some really fascinating aspects of the context assessment. Nadi, she did such a beautiful presentation which talked about the importance of building local research capacity and ongoing sustainability of projects and really engaging consumers, be it the ministry, the consumer themselves, and that delicate balance around that perfect study design and feasibility. And within her context, it was kind of not overshadowed, but the turnover of the government and that political context really has played not havoc, but it's kind of had an impact. But kicking on and moving forward was really the focus of that aspect. for Nadi and my stuff. It was really just talking about the cultural, assessing and responding to the Aboriginal cultural context within GACD projects, and how crucial it is that GACD fund projects that that value and respect Aboriginal culture and incorporate Aboriginal researchers in their proposals, and that we as an organisation continue to move forward and to ensure that there are really strong mechanisms for support and care, not only in our individual projects, but across the Indigenous projects of GACD. Thank you.
That's great. Thanks so much, David. Any thoughts, questions from around the room? I'm seeing the chat is restarting again. Now we're all back in the main room. We have about 5 minutes till the formal end of the workshop, but I think it would be really good to hear from anyone else who wants to share a perspective on the issue of context. Is there anyone out there? Pop up your hand. Let me see if I can see you. Or pop something into the chat which you may find is helpful and can share relatively quickly. I'm not seeing any hands going.
There's a question from Julia in the chat which says about the preparatory phases and the initial engagement, that they take time to do well. And
I can speak to that if you like.
Lovely, thank you.
Yeah, so I mean it is related to context, but it's not a question about it really. It's just, you know, I find that it was originally in the timeline of the proposal, but of course everything does take longer than you think it's going to take, and particularly approvals even before you get to start those phases. So just wondering how other groups manage that. I mean, I think obviously we're just going to have to extend our project out, but it's definitely time consuming to do it well. So it's sort of an added challenge, I guess, when you're already trying to cram something very ambitious into 3 years. So any experiences or suggestions would be gratefully received.
It's a really important question, and yes, speaking from GACD, we're well aware that our one-off calls don't necessarily mean that you can do the formative task question as a one sort of research proposal and then come back necessarily later with a second, you know, now we've done the formative research, we're at that point where you're ready to go ahead with a full implementation project. Any other? Gillian, yeah, I see your hands up.
I can just speak from, you know, we've been very blessed because we're on our second lot of funding from GACD, which seems like a miracle. And, you know, I think also working in the context of Aboriginal and Torres Strait Islander services, it takes time to build those relationships and trust and take people along on the journey with you. And so I think that's the advantage of, you know, being able to stay in the game for a long time. You know, our first project, I think our methodology wasn't really right for the context. And then we had a chance to, you know, improve. We had funding in the interim from the Department of Health where we had chance to improve things. I think people signing up complex agreements with the university was problematic, you know, that we sometimes, you know, services just weren't willing to kind of, you know, go through all the fine print of the contracts that they have to sign. And sometimes we did actually try a phase which was funded by the government that where we only had 4 services sign up the contracts. And then once we opened it up saying, well, you can just do it without signing anything, we got another 36 services that we kind of got flooded, you know, and obviously that was a real barrier, but then we couldn't really collect any data much from those services because, you know, they hadn't signed any organisation consent or research agreements. But obviously the need was there. So it showed that they really wanted what we had to offer. But, you know, and then now on to our second GACD project, and we're just wanting to learn from the lessons. Yet we're kind of, you know, we do need to collect that data, you know, from you know, to be able to report things and to know whether they're making a difference. So we know we're just treading this fine line of like, what's the minimum that we can ask people to sign up to? How do we do things so it's not such a burden on the services? So it's just a lot of lessons we're learning, and just feel very privileged to be able to have that continuity, that we're kind of going from strength to strength and getting further chances to do it better as we go along.
That's great. Thanks so much, Gillian. I'm glad that GACD has proved supportive of your research in a productive way.
So we are actually going to go into our regional parallel sessions now, and as I mentioned, there'll be in the Americas, the European region and the African region. So just quickly, Cherie will open up the breakout rooms very shortly, and you can choose which one you want to go into. And just to let you know that if you go into breakout room 1, you'll be hearing from Lucy and Marshall, and they'll be talking about diabetes and hypertension in Peru, Colombia and Jamaica. In room 2, we'll be hearing about the European region and mental health implementation in Ukraine, and also cancer screening across multiple European countries. And that'll be with Konstantin and Violette. And then in the African region, you'll be with DK and Ruth, and they'll be talking about hypertension in Nigeria and mental health in Zimbabwe. So you've got quite a feast of different things to talk about. So
Janine, my name is Lucy Cordova, and I'm here representing the ANDES study, which stands for the Addressing Hypertension and Diabetes Through Community Engaged Systems in Puno, Peru. And today we're going to go over the ANDES pilot study. We're going to talk about a little bit about the challenges that we encountered during this pilot study and how we implemented specific solutions to these cases. In your right, you will see a nice and beautiful pictures about Puno, which is a city that is located in the southern part of Peru. One particular characteristic of this city is that it's located about 12,000 feet approximately above the sea level, and people that are used with the meters above sea level, this is approximately 3,800 meters above sea level, and mostly of its population is from indigenous origin, specifically from Quechua and Aymara population, and they represent 70% of the total population placed on Puno. So considering these fabulous characteristics that I want to share with you, let's go over with. Let's see. Okay, I have to do it manually. That's no problem. Okay. First of all, we have to understand what exactly is the ANDES intervention strategy. First of all, we base our strategy about using the Who Hurts technical package. As you could see in your right columns, we implemented different strategies in order for us to cover different topics and interesting topics in these cases. For example, we want to work with the help of the community health workers from Puno in order for they to carry out home visits and promote health coaching about the 5 moments that we understand for ANDES. What exactly stands 5 moments for? Basically, they will have to be in charge of recognizing the health status of the participants and also families while visiting at their houses. Also, they will be teaching about chronic diseases while providing counseling about adopting healthy habits. And also we want to adherence the medication intake in this population, because we find out this is an issue that is currently persistent in this population, and also promote them to actually schedule their follow-up visits with their health physician. So as you could see, most of these topics cover different aspects that Who Hurts technical package stands for, and this is going to be implemented in a specific population. Also, we want to do this work by performance and quality reporting. So we use technology like RedCap in order to register everything that we collected from our population in the most adequate way. So considering this, we have to remember, why should we work with community health workers and what kind of struggles or problems we find out? First of all, why community health workers? Because we know that this is a vast resources that we are not using in their most capacity, because most of the time they are that they are important, but actually in the field, when we want to work with them, most of the time people are not encouraged to work with them because they have certain trust issues. How what is their knowledge about health topics. But we realized by doing in-depth interviews with them that most of the time, the training that they receive is based on the activities that each health facility is in charge of. And most of the time, there is a difference between the topics that they cover, the methodology that they use, because this depends on the resources and availability that the professionals that belongs to each health facility have at hand. So we found that there is a lack of transportation for our community health workers that depends on their community resources most of the time to do their work. There's also the lack of adequate educational materials, especially in the context of Puno, which is very indigenous. So there's mostly material that is published by the Ministry of Health of Peru, but not for a general population. And also there's lack of economic incentive for them to carry out their important work. Also, why should we talk about health fairs? Because this is a strategy that the pilot of Andes implemented during this pilot. And this is something well known that is well promoted, is well known because both health facilities and community work hand by hand in order to promote health prevention. And there is different ways in rural and urban population can contact with the health facilities. But we find out that, again, lack of resources, personnel, and also connectivity with the specific persons, in this case, medical specialists, is an issue that is persistent in these situations. So what exactly happened during the Andes pilot study? Well, basically, we did 2 stages in this pilot. First of all, we did the identification of potential hypertensive participants using 2 important strategies. The first one was the health fairs, as you can see in your right of the window, and review the registry of the local healthcare facilities. But obviously, we have to encounter the authorization of these facilities, and we have to keep in mind that most of the time this information was not always updated, but those were the strategies that we want to implement. And also we carry out the baseline in-home visits in which community health workers does the Andes intervention that I previously mentioned. So there are certain characteristics in our target population that has to be about 18 years old or equal that age, and need to have a diagnosis of hypertension provided by a physician, and they are willing to accept their visit of their homes of our community health workers. So considering these scenarios, you have in your left the health fairs. How and where do we have to establish these health fairs? This is an interesting topic that we discussed in the Andes team, because with the help of the community health workers, we could identify strategic places in which population vastly go to do the daily activities. And also with the help of community health workers, we could overcome one important barrier that was languages. People that speak Aymara or Quechua were mostly afraid to go to the health fairs because they thought that mostly it's costly related procedure. But by the help of the community health workers, we could contact these people and told them, okay, this is a free blood pressure measurement that you can control your hypertension if you have the risk of that illnesses. And as you could see, people were waiting for us to be ready in order to start doing our daily activities. And also we have to consider that during this pilot study, it was during 2022. In case of Peru, we have still the COVID restrictions, and there was a very troublesome how to deal with this issue while visiting our participants during home visits. But we adapted different actions like using cover masks, be outside of the home. But luckily, our participants were very welcome and they accept in their houses and receive these interventions. And regarding the lack of resources, specifically for this population, as I mentioned before, and this intervention created a vast amount of different materials for them that consider not only the reality of the people, but also how well or what is the type of nutritionist needs that they require for have a healthy lifestyle. For example, a recipe book that considers local food and resources that are daily for them and considers hypertension and diabetes strategies like reducing salt and so on. So yes, we adopted the instructions from WHO, but we adapted locally for the context of Puno. And also we have reinforcement materials to provide them like control the hypertension, in something like a blood pressure logbook that they can see it at their homes and continue these activities. Why not doing digitally? Well, let's see why didn't we adapted digitally and instead using materials physically. Let's go over the key findings that we found during this pilot study. First of all, by using the strategy of screening enrollment using Health First, unluckily we find out that doing it in the community, only 2.8% of enrollment rate is what we had during this pilot. Instead, the registries, even though they sometimes have inadequate registries from the different health establishments, they represent a 78% of enrollment rate. That's something surprising because we were expecting to have a higher rate during the Health First. So in this scenario, we as a team decide that the implication for the main study is to switch the strategy to rely more on the registries provided by different health establishments, either private or provided by the Health Ministry of Health of Peru, but also keep the Health First, but instead of doing it at the community, we are going to switch it to do it inside the health facilities in order to cover the most amount of people with chronic diseases. Also, when we were doing the Health First at community, most of the time there was a very difficulty for participants to actually go in and set up an appointment with their head physicians in order to receive an actual diagnosis of hypertension. So even though we probably have certain ranges of blood pressure that can generate alarm, so probably you should go to your head physician. Setting up this appointment by themselves, by the participant was pretty difficult because this is something that Peru is having. The fragments of the health establishment is an issue. So instead of that, in promoting that in the main study, we are expecting to create a multidisciplinary team that is going to be in charge of monitoring and controlling the hypertensive and diabetes status of the population. Also, instead of cover all the 5 moments in each of the visits, instead of doing that, because they find out that during each visit is going to be repetitive and lengthy, we are going to cover one aspect of the 5 moments in each visit, and this is going to be evaluated by our field workers and community health workers. Instead of using text messages, and why we didn't go digitally with this intervention is because most of our target population didn't have our own personal cell phone. Most of the time they have a family phone. And this is very interesting because one person might think, okay, why don't go digitally? Well, considering the barrier of idiom, the barrier of economic resources too, population will have lack of these resources. So that's why instead of participants receiving these key messages, are going to be community health workers, the people that are going to have those messages, and they have to relay that information to the participants. Why community health workers have cell phones? Because they work hand by hand by health facilities. So this is something expected for them to have it ready. About the medicine uptake, we find out that there's mostly unavailable for participants due to stock out, but this is not something that's happening because there's lack of medicine in Puno in general. Most of the time is due to the administrative and transportation issues that don't go from central Puno to the rural areas. So we are going to implement for the main study the participation of community health workers as a home delivery service of these medicines. And finally, instead of doing a cluster randomized trial, because we find out that most of the time participants, when they have trouble to seek out appointments, they want to go to either health facility, so they access to more than one health facility. And because of this, we decided to switch instead of cluster randomized trial to an individual randomized trial. So this is something that we find out. I'm sorry for taking 2 more minutes, and thanks for your attention.
That was absolutely brilliant, Lucy. Really, really interesting. And yeah, I think it's really exciting the way you're using the healthcare workers and that you changed the intervention and implementation as you went along to make sure you're fitting to the actual context. That's really exciting. So if you want to stop sharing, I think we can move over to Marshall now, and then we'll have some questions at the end. But that was really good, really interesting.
All right, thanks very much. All right, let's see if I can find my presentation. Okay, so yes, I found it. Let's see if I can do this. and then we can kind of go from there. All right, so I'm going to talk a little bit about some of our evaluation of context for the CATCH study. I think the first presentation had a lot of one of the papers that I read in preparing for this, which is about context and what we should be evaluating at what levels we should be looking at and so on. The CATCH study is really around implementing team-based care for hypertension management to improve blood pressure control, both in Jamaica and Colombia. So we have two settings which are slightly different in terms of the healthcare service delivery. Jamaica, primarily public run system of clinics that are managed and funded by government. But in Colombia, it's a sort of contractual service where practitioners within each of these settings is contracted by government to provide care for patients with hypertension. And so in trying to pull together a team approach to hypertension, there are kind of different things that we had to think about in each setting. And we went about this in a couple of ways. We actually changed the framework we were working with. We started with the REAIM framework, and then we moved to EPIS. And in this case, the issues around context are related to what is listed here on the inner context and outer context. And for both settings, we actually used a similar approach, a combination of focus groups, key informed interviews, and patient surveys, as well as investigator opinion and experience to understand the context in which we were operating. And so I'm going to present the findings, and I'm glad Althea is here on some of the findings from these evaluations. I've actually presented it deliberately this way because I've kind of looked at outer context and inner context, but you'll notice that for providers, it starts with outer context, and for patients, it starts with inner context. And I think that is because of the experience that each person had. So going back to the EPIS framework, we looked at the responses that providers gave under each of the different areas. So there's leadership in terms of outer context. There's a lot of concerns about how well international guidelines were implemented, who would be responsible for what in every setting in which they were working, resistance to some of the initiatives that might come with team-based care, like task shifting, challenges with funding, because they felt that there was even very little for what they were doing normally, much less to start adding interventions, that many clients they felt were unaware of what services the health system had for them, and that advocacy would involve primarily improvement of available resources and some additional support. On the inner context, however, the issue of leadership was really about management and organization internally around how well the clinics were being staffed, how well the staff were interacting with each other and communicating to ensure that patients would have the best outcome. From the patient perspective, their inner context really, in the terms of leadership, was related primarily to communication, how well the health team was communicating to them, the physicians, pharmacists, and other members of the team. The organization was also important in terms of how easily it was for them to access care and other processes that were taking place within the clinic. They were concerned about staff turnover and rotation. So whereas the physicians and the other providers and administrators thought about lack of staff, they were concerned about the fact that they didn't see the same people each time they went. And then from the outer context, the things that they saw as important in leadership were really around whether or not the healthcare system was being managed properly by the government, particularly now that the COVID-19 pandemic was in place, and this was the time at which we had done this assessment. They're concerned about the quality of care they were receiving, and they felt that funding was spent on some things that the government felt was important, like medications, but they felt that money should be spent on other things which they felt were important, like lifestyle, eating, and other things, or even transportation to get to and from the clinics for care. They felt that they needed to know more about hypertension, and especially how natural remedies could be incorporated into care. And then in terms of advocacy, a lot of them felt that the family was their primary advocate, and engagement of the family would have been important. And some of these came through in the survey that was done among the patients. Again, the inner context issues of leadership and patient communication came up in that. The organizational processes in terms of access to care and long wait times, getting medications was a challenge. And in the outer context, in terms of what the client's beliefs around hypertension were, the relationship with stress and other external factors, preference for natural approaches to care, and then the importance of family being their primary resource for support and not really the clinical services. Interestingly enough, this wasn't a formal part of the assessment, but when we were thinking about the project, we used to meet with, well, we still do meet with some retired members of the health team who have been noted for their successful implementation. And in their idea, the issue of context was really around personality. So I thought it was very interesting. And thinking back about the talk that we had before in terms of how things changed. So in other words, a lot of the people who had previously implemented things were very, what we call strong leaders. And so they felt that all this modeling wasn't very good, just need a strong leader to tell them what to do and it will happen. Anyway, back to lessons that we learned from our context assessment. I think the ideas of what we learned were really around things that we would change. I think one of the first things is how we interact with the leadership, because as part of the implementation process, we actually have to interact with a lot of policymakers. And it's important for us to be advocates for patients and providers, sort of escalate issues which are of concern to them in their day-to-day management. I think the other thing where it's also been important is our adaptation of some of the materials that we're going to be using for the health coaching, which is also part of the intervention, and making sure that we address specific needs in terms of patients' understanding of lifestyle, incorporating natural medicines and other things which are of concern to them. The other thing that emerged as well is even in terms of pulling a team together, there are some specific things that we'll have to address, not outside of just a common protocol and how you titrate the medication, but the issues around team dynamics and team communication, because these will be very important, because the study has a sort of testing phase, which is our cluster randomized trial, but then a scale up at which we want to begin to move the lessons we've learned to a higher level. And finally, one of the things that we have to do in engaging people for this intervention is not just to focus on some of the traditional resources, but definitely the patients would want their families to be engaged as part of the process. And so we are taking a number of these lessons into consideration in moving forward. So with those few slides, I'm going to stop sharing.
Thank you, Marshall. That was... Oh, sorry.
Yes, we're hearing. We're seeing and hearing you.
I have no idea why I was echoing so badly there. Sorry.
Yes.
That was really interesting. Really, yeah, really exciting and really interesting to hear that both of you actually made adaptations as you were going along. Particularly thinking about your idea with the, well, you just need a strong leader and they can just make all the decisions and it will all be absolutely fine. I think you do see that a lot in implementation and interventions. I guess what I was going to say is if anyone has any questions, please feel free, just stick your hand up or pop something in the chat. Either way is good. But I guess what I was going to ask, which is kind of also going back to what I was talking about this morning, was that people also noticed that ministers, so you know, outside of the kind of healthcare providers and the patients and their families, they actually, one of the biggest adaptations they had to undertake was because the political climate changed whilst they were kind of putting the intervention in place. And I just wondered if, seeing as both of you had experience of COVID, that there were, you know, you had to make changes because of that as well. Go ahead, either of you start, whoever feels most vocal.
I'll be very short. I think, well, for us in Jamaica, it's been fairly stable. And I think for Colombia, we haven't had that dramatic shift. I think a lot of the issues that we discovered around COVID were that maybe it picked up for us issues around how well we could engage with patients. So for instance, even the ability to get information we had was challenged because people were not coming into the system. But it also highlighted, and one of the differences that we've seen is that for Jamaica, which doesn't have electronic records, whereas Colombia uses that electronic record system, the ability to identify patients who are uncontrolled and to engage them in the study is a lot more challenging. So we do a lot more hands-on and a lot more direct recruitment, and they seem to respond better to that than, you know, telephone engagement.
In the case of Peru, we also face these troublesome issues due to COVID, especially the restrictions that in Peru we have to face for a long period of time. Especially we have to consider that in 2022, we were carrying out our visit at home from our potential participants, and doing this interaction, considering that most of the time from one visit to another, one participant might get ill due to COVID, it will interrupt the session and subsequent planning that we have in the first moments. So we have to consider those scenarios and also take different actions on how to exactly deal with them, and in the information that we are collecting, how we are going to represent finally in the results that we are going to present.
Ivliki, do you want to ask a question?
Yeah, thank you both for really interesting presentations and very concrete from Lucy. And I also love the way in Marshall's presentation how the participants were looking at the contextual factors, like from very different perspective, like the same kind of constructs meant different things for them. But my question was really about COVID as a context, and how do you perceive that as influencing other like many other parts of or components of the context and what the interactions were there. Does this question make sense to you?
Yeah, yes. Actually, it's a very important context that we've been operating in. I mean, it never occurred to me until you made this point, because a lot of the things that we had thought about early on were things that we would have done in the setting where we were operating in a sort of more or less normal situation. I mean, Althea's on the call. We had to do the interviews virtually, so I think that was important. In a way, it kind of allowed us to test some other things that we may not have had a chance to do if we weren't forced to do it. So like even considering things like technology or thinking through how we can interact with persons. But it also had for us the ability to, or cause us to think around contingencies that we'd have to have in place should we have disruption. And COVID is maybe one example, but for the Caribbean, we have a lot of natural disasters. So we could be in the middle of the intervention, and then we have a hurricane which affects one part of the island. How do we continue with the intervention? It's disrupting medications, and people are refocused on one particular important disaster. Are there any things that we can put in place? Because these are important questions that will have to be addressed outside of this project or even in the setting of implementation of other programs.
Also, I want to share that in case of understudy, we have to consider before implementing the pilot study, the negotiation and presenting the project to the head, the key persons, in this case, the Ministry of Health. There was a barrier due to COVID because there was a focus, as Dr. Marshall was mentioning, to treat people with COVID and not communicable diseases. So it was a challenge to mention, okay, due to COVID, there's also a huge vast amount of people that are lacking their usual medicines. They are lacking of accessibility to the health centers. And it's not only COVID treatment that we have to focus on. We have to focus in the vast amount of other illnesses that were relying not only 1 year, mostly more than 2 years, especially in Peru. They have to wait that most of the hospitals were available in order for them to have an appointment with their head physician. And most of the time, this is a trouble issue that was carried out before COVID pandemic was established. So this is something that is very complex. And also the trust that people may have in that moment to receive a person that is completely not met before in any circumstances was very challenging for our team. And I was very happy that our community health worker was a key factor in order to introduce us to these families and open their arms to this study. So this is something I want to mention about this experience.
Yeah, that's very interesting. And really, I think that the COVID as a context is a really good showcase of what complexity means and how it influences everything. And the disruption that it caused then also opened windows of opportunity for new systems, as Marshall says, that were created during the pandemic that wouldn't have been in place otherwise. Yeah.
Thanks. And actually, I was just thinking about one experience. I'll just speak very quick because we were actually trying to recruit patients for a study, and then when we were doing it, we spoke to the participants in one section of the island, and they had been trying to do a number of things to ensure medication delivery, including home delivery from a mobile pharmacy. And one of the first things that they discovered was a lot of the contact information that they had for the participants was outdated. So it was done at registration, and people changed cell phones very often, so they were able to contact them. And then when they would make these journeys to the communities, everybody in the community has the same address. So, you know, the address is a community. So you'd go there with all these prescriptions and you have no idea where the person lived. All you had was a community as the address. So I think that was very telling for us in terms of some of the things that we would have to think around, even as we were making adaptations and trying to address issues around medication access, etc., for participants.
I think it's really interesting also that you had the kind of context of having somewhere where you didn't have digital records, so that kind of tracking of people is really difficult. And I was kind of thinking about, because both of your projects are scale-up projects, aren't they? So they're both kind of already based on something that was already, you know, that was there. So was it different? Did you kind of think differently about the context when you were going into the scale-up project, or did you go, no, we know everything, it's all there already?
Yeah, I'll start. Well, I guess we're not at the scale-up section yet, so we're at the concept session. So I think the lessons are actually quite different, because even in terms of when we see our recruitment numbers and engagement, realize that it actually takes a lot more of a different kind of work, and so that will be very important as we try to think around how we make this bigger in Jamaica at a national level, in Colombia at a regional level, just based on the resources that we're recognizing are in place now for use in the first phase of the project.
In case of Peru, we want to scale up this project, but first we have to see what actually is working and actually is a great result after implementing on this project. So first, we are starting the main study since this year's March of this year. So this is some interesting results that we want to find out after COVID. So this is a whole different context that we have to evaluate again, because context from 2021 to 2022 are totally different after COVID restrictions are lifted. And also was what Dr. Marshall was also mentioning is that the information that non-communicable diseases have in different health establishments, it was like COVID period, it was like a stop. Let's stop every information that we can have from our population and let's resume since starting 2023. That's something very interesting and impactful, because here in Puno, at least in Peru, they don't rely on digital systems yet, because we found out they don't have access to connectivity, they don't have the resources, they don't have the people trained for dealing with that. So it's interesting to see that people are still relying on paperwork and all this information is outdated. Most of the time, people with hypertension or diabetes diagnosis no longer are alive when you actually visit the address homes. So it's pretty interesting to see that situation on these days, comparing to another countries that they face these scenarios totally different due to COVID context.
I think what I'd like to say is thank you both so much. Like, fantastic talks, really interesting, really exciting. Definitely looking forward to hearing more from you and more about your projects. But yeah, we're closing in 24 seconds. So I guess if everyone heads back to the main room, and thank you. And I'm just really enjoying seeing you smile, Marshall.
Yes. All right.
Thank you all
Thanks, everyone.
so much.
Thanks, everybody.
Prevention work or not work, right? So we invited all the stakeholders we could think of. Of course, the delivering agents, the community health workers, the nurses that are working in the primary healthcare clinics, the city health authorities, patients, like anyone we could think of. And then we were faced with, and I'm saying that with all respect, with the hierarchical ideas or hierarchical beliefs that exist here in Zimbabwe. So we thought, if we want to have a lively group discussion, we cannot put people from different hierarchical groups in the same group. Because people who feel themselves as being on a lower hierarchical level will not speak up. And so my colleagues and I were discussing, how do we do this? So we came up with, and this is not a new thing, I'm sure you've all done that. We thought, okay, we put them by profession. So this is a group of nurses. And yes, they were lively discussions. And we had a group of community health workers, and there were some lively discussions. But that meant, of course, that we left that space of having that heterogeneous kind of like debate, like different opinions, maybe different viewpoints. So, and that's always something to think about. Like, how do you keep people in a space where they feel free to share, but how do you keep also the context of this kind of information gathering in a way that it inspires new thoughts? Next. And then I wanted to tell, and I'm going to make this quite short. So this, I wanted to show that you, many of you might have heard about the PRIME, the Program for Improving Mental Health Care, that was led by the UCT and the University of Cape Town. And they came up with a really, really, really comprehensive tool of context assessment. We did not use this one in our GACD funded study, but I still felt it was extremely important to show it to you. And I've been sending that to people that I've been working with. And so it covers like all the relevant context one can think of. I mean, it's really, really comprehensive. You can Google it and download the tool. It looks at all the mental health politics and policies and plans. And obviously this is mental health related. Yeah. It looks at the mental health treatment coverage on a district and on a community level. And then it looks at how's any kind of mental health care that is delivered, monitored and evaluated. And the feedback I got from people that I gave that to and said, hey, this would be great. Then we have a situation analysis, and then we know what we're working with. So we're not reinventing the wheel, for instance. The feedback we got was often, wow, that data is not available, or we don't know where to get the data, or the data seems a little bit like we don't know if we really can get it, and who should we ask? Who in maybe the many people who might have access to data are the most like trustworthy here, right? So look at this one. It's I mean, on this one photo you can see that they look at all the different therapeutic styles that are available somewhere, and often in our very low resource settings, not much of this will be happening, right? I also find it very good because you can use it pragmatically in terms of like what is applicable for you. Okay, and then the next one, I think this is my last slide already. I wanted to talk to you quickly about the theory of change, which I'm sure you have heard about as a tool to bring people together and gather information. Often it's used specifically for creating buy-in from stakeholders. And at the same time, it is heavily context revealing of what is going on. So we use that in another study, not the GACD funded one, where we looked at how to create our task shifted program and link it up with care for, detection and management, referral and management for more NCDs. So we did this theory of change workshop, and again invited all the stakeholders we could think of, from like the medical field, from community health workers, nurses, authorities, policymakers, and very important in our context here as well, traditional healers, because obviously there has to be a synergy between all of this. And again, when I was leading this theory of change workshop, and my experience was that obviously we have to start with like a briefing, right? Like we have to explain, why are you all here and what do we want to work towards and what do we want to achieve today. And to lead the theory of change means we have to be extremely subtle in our presentation, because this is a moment where we can influence a lot, right? And we don't want to influence people's ability to think freely and come up with new ideas and think outside of the box, right? We don't just want to repeat what's always been there. So this is actually quite an intricate and comprehensive approach that I think needs to be done with care. And yeah, I mean, I'd love to hear if other people have experience with theory of changes. Let me just check what else I wanted to say about that. So and again, that same thing is a theory of change can have, like, you can have like 10 people in the room or 50 or more. And how do you get people to engage and to stay engaged, especially in a context where, and again, I'd be interested in hearing your experiences, where often projects are being done and we are less often, maybe if I can say that way, create a way of having the project really being implemented and even scaled up, right? So people have had a lot of experiences of being part of programs and projects, and then things fall apart, and it was just a project and it never came, nothing came of it. So there's also like a lot of sort of like skepticism and maybe less hope in people. So the process of gathering the context here is important in terms of being trustworthy and being reliable to people so that they continue working towards a better healthcare system on that level. So I will stop here and hand over to my colleague. Thank you so much.
Thank you so much, Ruth. That was a really interesting presentation. Great to hear your experience and some of the things you said, something around context assessment. You don't always know it's really context assessment. You know, you're doing things, visiting clinics, meeting with people, talking, and how you're getting around some of the challenges with making sure everybody has a voice. So yeah, really practical. Thank you for that. What I'd like to do is invite DK to present, and then we'll have a short time of discussion. So maybe others have things they would like to share about work they're doing or have questions for Ruth and DK. But if I can invite you, DK, you should be able to see your slides, and just let me know when you'd like to move on to the next one. Thank you.
All right. Thanks so much, Margaret, and good evening or afternoon or whatever, depending on where you are. So my background is cardiology, internal medicine cardiology, and I work at University of Abuja in Nigeria. And we're running a program. We call it the Nigerian Sodium Reduction Program, whereby we're trying to, for the first time, assess the level of salt intake in the Nigerian population and in also our food. So I will be sharing some of our experiences around this. So next slide, please. Next slide. So I won't bother us much on this because we have had a background talk around this, but context, as we know, is defined as everything else that is not intervention, but we influence intervention, implementation, and outcomes. And if you don't handle context very well, then you are sure that your intervention will likely fail. And context is very, very important for implementers, for managers, for policymakers, regulators, and purchasers of healthcare. Next slide. So what are the levels of context we considered in our Nigerian sodium study? So we looked at individuals and families. So that was the first mapping we did. We looked at the community level. We looked at the local government level or local authority. Then we looked at both state and national government levels. Then we looked at professionals because we're going to be working with the laboratory scientists who are going to be assessing 24-hour urinary sodium estimation, and also with dietitians and nutritionists. So they're going to be very, very important. And we also look at non-government organizations like World Health Organization, Resolve to Save Lives, that have great interest, around salt reduction in different countries. Next slide. So assessment of context. So what do we do? We use different methods, and it was based actually on the CIFAR framework. So one of the things we did was using in-depth interviews. So we conducted in-depth interviews both at the family level. We engage with community leaders. We engage with policy makers at the local government level, especially directors of primary healthcare who were in charge of healthcare in local authorities. Then we looked at the state government levels. We're working in 3 states of Nigeria. Nigeria has 36 states in addition to the Federal Capital Territory. So we're working in the Federal Capital Territory. We're working up north in the state we call Kano, and we're also working in Ogun State in the southern part of the country. So we engage different persons from the local government to the state level and national level. So we interacted with Federal Ministry of Health, NAFDAC. NAFDAC is like the FDA equivalent of Nigeria, Standard Organization of Nigeria. So we use in-depth interviews. We also use focus group discussion. So, for example, when we engage with the Federal Ministry of Health, we had focus group comprising 3 to 5 persons. When we engage with NAFDAC, for example, we did in-depth interviews. So we use different methods depending on people's availability, people's preferences. Then we also did informal engagements whereby we visited people, or over some conversation on the phones. Then more formal stakeholder workshop. So in 2011, we had a big stakeholders meeting, November 2011, and that meeting was attended by over 450 persons. It was both virtual and physical. Over 300 persons attended physically, and about 150 persons attended virtually, and comprised policymakers, healthcare practitioners, manufacturers, non-governmental organization, professional body like scientists, the Nigerian Medical Association, and so on and so forth. And in that meeting, we had a lot of, it was more of interactions, and we learned a lot. Some of the things we incorporated into our intervention. So this was really at the formative stages, because for the first 2 years, we did more formative for the NIH grant, what we call the UG3 phase, before we moved into the UH3 phase. Then we also had to look at some databases, because we're working on nutrition. For example, what we call the NDSRO database, which is a global database, the West African database, the Nigerian database for food. Also, we looked at that. And we've had some of our publications, as you can see, in +1 and also European Heart Journal. So in case you're interested in going through them. Next slide. So in terms of context, so level of context, I said before, we engage the families, we wanted to know their levels of our awareness about the dangers of excess salt in their diet. What are the social norms? For example, putting table salt, at dining, or eating out of home, or cooking. We wanted things like that. Community engagement, wanted to know how best we could engage the communities, how best we could create awareness and education, and to be able to distill our findings when they eventually come out. Then the local government level, we're looking at the leadership structure in terms of implementation of salt policy. Who are the people we are going to meet? And here we interacted so much with the people we call the directors of primary healthcare. Then the state and national levels, we looked at implementation, or what we call a national multi-sectoral action plan. So Nigeria has a national multi-sectoral action plan, which was developed in 2019 and is going to run till 2025. So we're particular about what is the salt policy in that action plan. Then looking at professionals, we looked at how can we build capacity in nutrition. We wanted to look at the level of nutritionists. Do they have experience in conducting nutrition surveys, especially around 24-hour dietary records, retail surveys to shops, and also we wanted to look to science, the scientists, laboratory scientists, if they were very conversant with conducting 24-hour urinary sodium in the 3 different states that we are working in. Next slide. So we incorporated some of our contextual lessons into our implementation process. For example, when we engage in nutritionists, we saw that there was very low level of expertise in able to conduct population level nutrition surveys around dietary recall. So it was also, we had to then started working with Nutrition Coordinating Center of University of Minnesota, they started training our nutritionists and dietitians on how to, and certify them after a series of training. Most of these training were online then, with a lot of practices and assignments with feedback, and they got certified to be able to do to carry out population level nutrition survey in the 3 states we are working in. We also went ahead to look at the database, the National Data System for Research for Nutrition, and how does they compare with our recipe, the Nigerian recipe, and we incorporated 50 Nigerian recipe into that, adapting it so that it will be suitable for the Nigerian population. Then we looked at the scientists collecting 24-hour urinary, so there were training and retraining of this. And also at the state and national level, we started expanding our relevant stakeholders. As we met with stakeholders, they felt that more people should come in from education, information, planning, and budget, that they were going to be very useful at the end. And also involving people we call the organization, we call the Standard Organization of Nigeria was suggested, and now we have incorporated them as major stakeholders in our advisory board. Then expanding the SOT policy document in Nigeria, especially making it more holistic, is another thing we're trying to do to incorporate, especially as our results start coming out. Then also incorporating source substitute, whereby we can replace some of the sodium with potassium, which has been found to be helpful in reducing blood pressure. Next slide. So this is one of my last slides, but we have some favorable contextual factors which has actually helped us. Number one is we've been able to align with the STEP survey of the Federal Ministry of Health. Now, as I'm speaking, there is training. There has been a national training, now a zonal training, so we're preparing for the STEP survey. We have been able to align with the Federal Ministry of Health because we've incorporated them into our study, into the advisory board. We have a great working relationship. So now we're going to be enriching the STEP survey data with 24-hour urinary sodium estimation and also dietary estimates, with dietary recall and so on and so forth. Then another thing that has helped us is leveraging the National Multi-Saturation Plan. So there's a policy. During the talk, they're talking about timing of policy. I think this policy just came at the right time when we're planning this. So we have been able to leverage on this. One of the key points of the policy is reducing salt consumption in Nigerian society so as to reduce hypertension and then cardiovascular disease. Then ability of human availability of human resources. So we have a number of scientists, a number of nutritionists and dietitians that we could just train and leverage to be able to conduct our study. Next slide. So in conclusion, so we know that contents in relation to implementing evidence-based intervention is the environment or setting in which you propose changes to be implemented. Understanding context is crucial for successful implementation. Evidence-based interventions are implemented in complex, as we have heard earlier, multifaceted and dynamic environment, which arguably means that the same intervention would rarely work in the same way in different contexts. Next slide. So such content will determine, above others, the acceptability of the intervention in a given socio-cultural environment, and all identified contextual factors should be taken into account for any intervention to be effectively implemented. And that is one of the things we identified that we needed to train our scientists, we identified that we needed to train our dietitians, we identified that we needed to expand our relevant stakeholders, especially the advisory board, if there's going to be a buy-in. And we also identified that there's already a policy document driven by the Federal Ministry of Health, so we have to align closely with them so that there will be a buy-in into our program. So next slide, I think that is a thank you slide. Thank you very much. That's a picture of Abuja. So I expect you to visit Abuja one day and visit me in Abuja. Thank you.
Thank you, DK. Let me just stop sharing. Thank you, that's really interesting. Salt reduction is such a challenging thing, and it's really interesting to hear about how you've been looking at context at all the different levels and the different people who need to be involved and the stakeholders who need to be engaged with such a diverse range of people. We've got about 5 minutes left for questions. I've seen a few popping up in the chat, and some have, I think some of you have been responding to each other already. Sorry, just going to, if anybody else has a question and would like to raise their hand, we've seen responses here already. We have a question just come in from Gladys. How do you know when to stop or limit stakeholder engagement, especially when you have limited resources, both time and finances? I think this is probably a question for DK.
Great. I mean, that's a very great question. So the first thing is to map your stakeholders. So they have stakeholders, you say these are very relevant stakeholders. Maybe these are relevant stakeholders and these are less relevant stakeholders. So the best way to go is to start with very relevant stakeholders, very relevant. Then if you still have the bandwidth, of course, then you go to the second level. Yeah, then you still have the bandwidth to go to the third level. Then it depends on how much time do you have for your project. So those things will determine how much personnel do you have. But if you do a good mapping, then start with the most relevant persons. And then do you have time? Do you have the bandwidth? You reanalyze, then you can go to the second level and then get to the third level. So it all depends on time. It depends on how much time, how much resources you have. So limiting it is yours. But the most important thing, engage with the most important persons first. Because if you don't engage with the most important persons, then you must have lost a lot, you know, at the end.
Thank you, DK. We've also got a question. Ruth has already responded. Thank you, Ruth. Do you want to expand on that a little bit? Talking, because focus groups are obviously used a lot. When would you use focus groups? Do you want to just explain a little bit more from your experience?
Yeah, I'm happy to. Thank you for that question. Also very exciting here. So I think, okay, going back to DK, what you just said about the stakeholder groups, right? And the different powers they have and the different, it's interesting when you said go to the most important ones. I guess that again depends on the project you're doing. Like, are you looking from what level are you looking? Like if we think the patient groups or the receivers, the beneficiaries or something they're not powerful, right? Like they're not powerful in the bigger scope. They're like on the receiving end, but they're the most powerful for a program to work or not work, right? Because if these people are not taking it up, you can design the most biggest programs ever, but nobody's coming, right? So but they won't be seen as loud. So and often patients are not, or patient groups are not really like exposed to being asked for their opinions. That's why I think focus groups are really good, because then they sort of like they work together and learn together what it's like to be in this. And I guess this is this like the participatory approach that we really want to learn from the I don't like the word ground, but I can't think of another one right now, but where it's happening, right? And then with like delivering agents or like healthcare professionals, whoever they are, I think depending on what you were looking for, semi-structured interviews can be really, really good there.
Yeah.
But again, it depends.
Yeah.
I mean, if you depends on the model you got, like if you do something like this, for instance,
I agree with you. So it's not the powerful, so it's about the most relevant. The most relevant might be the patients. For example, we have a study on hypertension in Nigeria that we are doing in FCT. We have enrolled over 20,000 persons. The most important stakeholders are the patients. So when we started our stakeholder engagement, we started with the patients, then followed by healthcare practitioners, not physicians, non-physicians, because at the primary care level, you have more non-physicians. Before we got to physicians, the physicians are the least important. They drive the policy, but then if you don't have the patient coming in, if you don't have the non-physicians taking the blood pressure, you will not succeed. So it is most relevant. They might not be powerful. They might not have the money, they might not have, but they are the most relevant. So I think knowing is quite important. What is your intervention? So it depends. But for the sodium study, we have to start with the policymakers because they drive the policy. In short, it is quite complex. If you don't have a policy that is driven, people will not align, manufacturer will not align. It's a very big, difficult, it is tricky. So defining your stakeholders, matters. Like you said, it depends on what's your intervention, that will determine your approach.
The questions coming in, but we're out of time really. But thank you so much to Ruth and DK for really practical presentations and really sort of grappling with some of these issues. I feel like we could carry on talking for a lot longer, but our time is limited. Thank you all, the rest of you as well, for participating, asking questions. I hope we've all learned something from this, and yes, continue being in touch with each other.
Very quickly ask if you will share a quick reflection on a hot topic, something that was recurring, something of interest from your breakout room. Martin, I'm going to put you first.
Thank you, Morven. Yeah, we had the pleasure to hear from two speakers. Obviously, a very interesting situation in Ukraine around mental health and the management thereof, as well as cervical cancer screening across Europe. And I think obviously from that discussion, it emerged that context is something that's not static, which we've already heard from the keynote speaker as well, and that it's something that's constantly evolving. And I'm going to make an observation here that I think that in implementation research at the moment, we still, and please let the speakers correct me if I'm wrong, we still consider it something that's relatively static, that we assess at one point in time to look at relationships between context and some of our outcomes, or to inform the development of an intervention, while possibly we need to look at context as something that's more fluid, that we repeatedly assess throughout a project, that we allow to inform changes over time with the work that we're doing, which might not be feasible or realistic in some of the conventional research approaches that we use. So that is my observation, but very interesting speakers and an interesting projects.
Great, thanks so much, Martin, for that quick synopsis. And next, I'm going to turn to Althea.
Okay, my connectivity is not that great, so I hope you'll be hearing me. But also in our group of the Americas, we got two great presentations where we had quite a lot of similarity in terms of, implementation to try to look at addressing non-communicable diseases, particularly hypertension, and one is for Peru and the other for Jamaica. And what I found interesting is that context occurred, or the important issues about context occurred both at the local level in terms of being able to adapt and bring in contingencies, not only in response to COVID, but also COVID-19, which made so, much disruptions to the health systems in primary care and of course in secondary care, but also context in terms of being able to respond to what the persons who you were trying to recruit needed. So I think the common barriers that were found in both studies is access to medication, issues which we're not surprised about, and more so in COVID, the response to that brought in new systems, such as delivering medications to the patients, but that it's in itself had its own barriers in that patient records and outdated patient records and the ability to find the patients based on the context of our countries where people don't have necessarily addresses where you can find them. So the address is an address for a community rather than an address for a home. But the things that seemed to be facilitators was that both the providers and the patients thought that the use of community workers and things to reach the patients where they were, and of course using the multidisciplinary team is very, very important to the context. Whereas, you know, you would have the physician delivering all of this, you needed to have more of incorporation of a multidisciplinary team, including helping the patient to understand their health issue through. And I think that's it for me.
That's great. Thanks so much, Althea.
Address this.
Thank you. Josephine, finally, from Africa region.
Thank you very much. I hope you're able to hear me, Marvin.
Can do.
Yeah, okay, good. So in our team from the Africa region, we received presentation from Ruth from the Friendship Bench for mental health in Zimbabwe, and then the Nigerian sodium salt reduction project by ODK. And both of them, their presentations resonated well with Pilviki's presentation, bring out the aspects of the multi-level context level, different levels at different contexts, the individual, the community. And interestingly, Ruth says when they started out, they actually didn't know they were actually assessing, context. It's later that in the middle of the project, not in the middle, but just as they were starting, when they realized we actually have to assess context. So, another issue that came out is that for the Nigerian project, using the existing policies, reviewing the documents was very, very important for them, and using the existing policies to see how to assess context. But what was a very, very interesting question that one member asked is, when you have little resources, when do you know to stop engaging the community, the stakeholders? And the response from the members was, it's very important that you map out your stakeholders when assessing context very, very clearly, especially in the beginning. Map out your stakeholders. And another suggestion was, we need to have this at proposal development, at budgeting level, so that we don't only stumble on context assessment or understanding your context when it comes to now starting implementing, then you realize I need resources to actually assess the context. I think that was really it from the Africa region. Thank you.
Thank you so much. And thank you to all three of the panel members who were listening so attentively during the breakout sessions. We've got about 5 minutes left. I'm going to throw open the floor for any further comment, perspective. Please feel free to use the chat box if it helps, if you have papers that you want to share, ideas that you want to share. If you've got any particular questions that you'd like to ask from the community, in effect, we're perhaps not going to necessarily be able to address everything, but do let me know. Now, in this case, it would be good if you raise your electronic hand if you want to ask a question, because otherwise I'm going to find it really difficult to spot the hands raised. Okay, who's this? Any questions? Sorry.
Am I allowed a question, Marvin? This has just come from, like, last year we had our first GACD Scale Up Masterclass, and I'm wondering from the panelists or from others how you feel context assessment differs or is the same for like a standard quote unquote implementation project versus a scale up project? And I know the panelists are quite well placed to comment on scale up. So any thoughts on the differences there?
Sure, that's not an easy question, I think. So I'm part of the SCOBY project, which is around scale up of integrated care for hypertension and diabetes in 3 different countries, Slovenia, Belgium, and Cambodia. And obviously their context analysis and situational analysis was an important component. Is it different? I'm not sure. I have to think about that a little bit more, but what I do, and I think I tried also to mention that in the breakout session, is that as long as we are comprehensive and structured in the context analysis that we do, then it will facilitate or at least comparisons to some extent around how context influences the scale up in the different settings. The second thing I would say is, and it brings me back to the observation, is that scale up to me is it's generally a long-term project and a long-term process, not something that happens in a year or 2. And the fluidity of context and how it influences your implementation efforts will drastically change during the scale up process. So context assessment can then not be a single activity. It needs to be something that's recurrent, and it needs to allow to inform how the scale up process moves over time. So I guess that might be a difference then.
Great, thank you for that, Martin. Any other questions? I think there's been probably a lot of food for thought. You might want to take away, think a bit more, reflect on what you've heard in this session. I hope you found it was of interest and of some help, maybe thought-provoking, if nothing else, thinking that you really see that context is complex, dynamic, evolving, changing, and how to deal with that is definitely something that we need to work out. Context is central to everything. Context of the new setting that you're moving into, context of the setting in which the intervention was originally shown to be effective may also be really important. When context changes in the situation in which you are undertaking your research, so it evolves and it's dynamic, there are issues there. It's a space in which we all need to continue to learn. I hope you found this was interesting. A great shout out and thank you to the speakers who have taken the time to prepare their talks and lead the discussion today. And also to the panelists who listened attentively to what was being said and have reported back. Thank you to everyone.